السلام عليكم ورحمة الله. بسم الله الرحمن الرحيم. السلام عليكم جميعا. أهلا أهلا. أحب أرحب بكل الموجودين معنا اليوم. يعطيكم العافية جميعا، وإن شاء الله تكون educational session لطيف not complicated و full of knowledge for everyone. أفضل الكل يعمل ميوت لو سمحتوا من جهتكم أو الكوردينيتور اللي معانا علشان ما نسوي أي interruption. شكرا جميعا. So, Bismillah ar-Rahman ar-Rahim. Today we are going to speak about aseptic technique of infection control. The outline for today is a bit of history and a little of background about aseptic technique, some definitions and terminology, types of each aseptic technique with examples. Aseptic technique ensures standards that we should maintain, and some recommendations for healthcare workers regarding hand and skin preparation of patient skin site only, aseptic technique enhancing components, and finally a conclusion. This session won't take long. Hopefully we will keep the time limited, and I will take all your questions at the end of the session if possible. So if we are going to talk about history, following observation of Ignace Similuis long time ago and other of 100 of years ago, the practices of aseptic technique is an infection prevention actually method that is recognized as an important factor in the prevention of transmission of healthcare associated infections. So this is a glaze of a history regarding aseptic technique that is well known long time ago, since Ignace Similuis 100 years back, right? So from the chain of infection, all we know that microorganisms are capable of causing illnesses to all human beings, and they can be transmitted both direct and indirect contact ways. So, able to interpret this transmission method, microorganisms and reservoirs, from reservoirs to susceptible hosts can be prevented these illnesses through aseptic technique. Meaning, aseptic technique is one of the tools that could break the chain of infection from the reservoir to the susceptible host by transferring the microorganisms, if that makes sense to you. The practice of asepsis is the key strategy for preventing this transmission. So this is highly recommended, that aseptic technique is crucial in terms of preventing transmission of microorganisms from the reservoir to the host, right? Aseptic technique improves patient safety and prevents healthcare associated infections that may negatively impact outcomes, including increasing of patient morbidity and mortality, increasing also the healthcare cost for patient and for their families, prolonging length of stay of the patient, increasing resistance of microorganisms and antimicrobials, and finally increasing physical and mental discomfort of the patients. So aseptic technique is one of the tools also that encourage and increase satisfaction, patient outcome, and patient safety as well. Definition of aseptic technique. It is defined as the process of keeping away disease or producing microorganisms which may be used in any clinical setting. Meaning, aseptic technique is doable because it is a technique. It doesn't require any fancy or luxury equipment to implement. It's very simple. It's a process of technique or steps that if we follow, that we could have a better outcome and results. Aseptic technique refers to practices that were designed to render and maintain objects and areas maximally free from microorganisms and aid in the prevention of surgical site, urinary tract, bloodstream, pneumonia infections that may be device or procedure related. Aseptic technique involve using barriers, such as sterile gloves, sterile gown, masks, sterile drapes, to prevent the transfer of microorganisms from care provider and the environment to the patient during the procedure being performed. Aseptic technique should always be performed when placing invasive device. Other components of aseptic technique include using appropriate attire, such as hand hygiene, skin antisepsis, appropriate use of sterile and clean devices, supplies and equipment, and environmental cleaning disinfection. All these components can enhance the aseptic technique outcome as well. Types, I can't see the top, let me try. Types of aseptic technique with their examples. We have 3 types of aseptic techniques, surgical technique and aseptic technique and clean technique. However, surgical and aseptic technique, they look similar. So I add them in one definition. Surgical or aseptic technique is applied including surgeries as well as other areas with invasive procedures, such as devices insertions, are done, such as placement of intravenous lines, urinary catheters, chest tubes, and any other indwelling device. Right? So surgical refer to surgeries, aseptic technique refer to any indwelling device or invasive procedure. Whereas a clean technique, on the other hand, or medical asepsis is another practice that is to prevent and reduce the risk of transmission of germs from one person to another or from one place to another. Clean technique leads to decrease of overall number of microorganisms that is present, rather than the absence of the microorganisms totally. So that's the difference between clean technique and aseptic and surgical technique, is that reduction or absence of microorganisms, right? Application of clean technique includes the rest of the situations. Wound care if the wound is post 24 hours of surgery, but post 24-hour surgery considered as aseptic technique required. After 24 hours of surgery, no, it goes under clean technique. Placement of intravascular device such as peripheral venous catheter and respiratory suctioning. Aseptic technique types and examples according to the ICA 2023. They mentioned that also clean and aseptic sterile technique, including also these listed points, but not limited to it, which is a proper medication preparation, dilution and prevention of medication, preservation of medication, a designated area where are physically separated from patient treatment areas. Recommended aseptic techniques and safe practices for preparation and use of the certain mentioned items. Single-dose medication vials or single-use ampoules. Whenever you use all these listed items, you should implement aseptic technique. Multi-dose medication vials, single-use device, syringes, needles, etc. Single patient devices, device like insulin pen, reusable multi-use devices, IV solution bottles, IV sets including secondary set and add-on device, ventilation circuits, humidifiers and nebulizers, and any other aerosol generating system. Moving to the next step, aseptic technique ensuring standards, reminders. To ensure aseptic technique implementation in any healthcare settings, these kind of steps could, if you check that during your rounds as an infection control practitioner, as an quality personnel, these kind of checklists will help you to figure out the gaps in your healthcare workers' practices. Are they implementing to the checklists or not? Are they following the policy and procedures of aseptic technique or not? And also by visiting, the medication room, the medical store area, these kind of visiting rounds or tours are very useful for you guys to dedicate and detect gaps that are over there. So first, essential safe practices for invasive procedures require device and supplies. Antisepsis, recommended PPE and procedures all should be available before you start an antiseptic procedure in the area. Safe practices require for insertion peripheral venous catheter, fixing, dressing, labeling, replacement of peripheral venous catheters. Hand hygiene, which is referred to a variety of practices aimed at reducing the microbial flora on the hands of healthcare workers. Examples of hand hygiene that is enhanced aseptic technique is hand washing, antiseptic hand wash, antiseptic hand rub, or surgical hand antisepsis. Maintenance also of skin condition, avoiding dermatitis and fingernails or artificial nails, or wearing any jewelries. All these elements, if you check them during your round, double check with your team, make sure that they are implemented, then your aseptic technique hopefully will not be broken. Separate clean area is available and maintained for preparation of medication. This is very crucial. This is very crucial in terms of aseptic technique and medication preparation. Also, the availability of the dedicated medication preparation area, which are physically separate from patient treatment area, as we said. Observe medication preparation process when the staff are doing it. Control ventilation with monitor for recording the temperature and humidity for the medication preparation room, which should be the range from 22 to 24, and relative humidity up to 70%, not more than that. Okay, at least one hand washing sink in the medication room that is occupied with hot and cold water supply, plain and antimicrobial soap and towels, and at least one alcohol-based hand rub dispenser should be available also. Second, for invasive procedures, sterile devices and supplies are used after patient skin antisepsis, such as sterile syringes, needles, and medications are used after skin antisepsis with approval antiseptic wipes. So, supplies should be used after skin antisepsis. And ask your healthcare workers, are these supplies available in adequate amount in the medical store or not? Double check, because if they are not available, meaning that they cannot implement the standards. Double check always the supplies availability, supplies integrity, supplies expiry dates. All these kind of notes can lead you to your staff compliance. Third, peripheral venous catheter is probably fixed with a clear written date of insertion, and to reduce the risk of infection and phlebitis, it is replaced into a kind of recommendation, like in adults, every 3 to 4 days, and in pedia, whenever clinically indicated. Fourth, preparation and dilution of medications are only done by ready-made single-dose sterile solutions, right? Never use in-house. All should be ready-made before single-dose sterile solutions. Number 5, single-dose or single-use vials is used for a single procedure injection in a single patient, and it's not stored for future use even for the same patient. That is full stop. It should be implemented and followed. Needles and syringe, including pre-filled syringes and holders used for a single procedure and injection too. Insulin pen are used for one patient only. Never share an insulin pen. Okay, so the insulin pen should written on the top of it, patient name, patient file, date of start, all this kind of information. Number 8, supplies are brought to the patient care area only when needed and with the amount is required, not more than that. And after patient discharge, all remaining single-use items are discarded, while reusable ones are sent to CSST for reprocessing. Even the unused reprocessed items with intact original wrap, they should be sent to CSST again, especially items left in critical care areas, such as ER, ICUs, etc. That's why we always say, minimize your supply storing in the patient area, because after patient discharge, this all would be a waste of resources, okay? Note, healthcare workers bring and prepare medication and supplies before initiation of the procedure itself to maintain the sterility of the practice and the aseptic technique integrity. Okay, minimize movement, minimize air flow, minimize staff replacement, closing the doors, etc. Whenever possible, multi-dose vials is used for a single patient. Whenever possible, okay? It is a multi-dose, but whenever possible, used for a single patient with a recorded name, patient name on the top of it, and the date of first use, right? First use mean when it has been accessed first time. This is the first use, okay? And discard after 28 days, unless the manufacturer specifies different shorter or longer dates, which they call it usually reuse life. If a multi-dose vial is used for more than one patient, they should only be kept in accessed in a dedicated clean medication preparation area away from immediate patient treatment area, right? Meaning in the medication room. The self-sealed wrapper cap of medication vial or an IV solution bottle is disinfected with approved antiseptic wipes, such as alcohol wipes, prior to any access to the bottles, right? IV sets, including secondary set and add-on device that are continuously used on infusion, such as hypotonic, isotonic, hypertonic, are replaced every 7 days. IV sets that are used to administrate blood products, or lipids or amino acid TPNs, for example, replaced within 24 hours of initiating the infusion. Okay, all these are standards that are enhancing aseptic technique practice. For example, in case if you have a patient with ventilation, to prevent VAP, this message is directly to the nurses and the RTs. To prevent ventilated VAP and ventilated patient, the ventilation circuit is only changed when visibly soiled or mechanically malfunctioning. Otherwise, too much movement in the circuit it might cause cross-contamination to the circuit. Next, sterile solutions are used in nebulizers. Never use non-sterile solutions in nebulizers and humidifiers or any aerosol generating system. We should use a sterile solution and change between patients and every 24 hours from the same patient, unless the manufacturer of ready-made sterile solutions specify different dates. Hand hygiene practice before breast milk expression, and the sterile container is used for breast milk collection and preservation. Also, this is an aseptic technique standard. Healthcare worker wear a mask during insertion of catheters or injections into spinal and epidural space. These tables are showing the recommendation for healthcare worker regarding hand and skin preparation of patient skin sites. For example, whenever you need to use gloves, clean gloves or sterile gloves, here is the example for the procedure. If you noticed, here we say medical asepsis, which refer to clean procedure, surgical asepsis, which refer to sterile procedure. You can take a minute to look at this table. For example, here any sectioning for bronchoscopy, endoscopy, it's clean, consider clean gloves used. Peripheral intravenous insertion, also clean, whereas urinary tract catheter or line insertion, CVL, sterile. More examples: spinal tap, cystoscopy, sterile, chest tube, skin biopsy, all are sterile technique. Surgical aseptic technique outside of the operation room. This is like whenever you need to practice an aseptic technique, but not in an operation room, or a best case scenario. In case of emergency or trauma, you have to do a aseptic technique wherever you are to save a patient life. So settings outside the operation room may not have the capacity to follow the same strict level in surgical suites, right? So we cannot apply to a surgical technique or surgical asepsis technique as much. So, for example, a critically ill trauma patient or neonate patient may be not unstable to be transferred to operating room, whereas you need to do a procedure right now. To accomplish this, you need some help elements that can aid you to maintain aseptic technique much possible wherever you are. In these circumstances, using environmental controls to maximize the reduction of microorganisms during surgical procedures is essential. These strategies include 8 points, right? First, use of a special treatment or operating room. If you can't use operating room, at least use a procedure room. Second, managing activity to reduce airborne transmission if procedures are performed at the bedside. Third, keeping the doors closed all the time during the procedure. Fourth, using physical barriers such as screens, if possible. If the place is not contained, if the place has no door, you can use the barriers as the screens as barriers to contain the place much possible. Fifth, minimize the traffic in open units. 6, exclude visitors and unnecessary personnel from attending the procedure. 7th, avoiding cleaning activity in the area during the invasive procedure time. 8, providing an additional environmental control such as ventilation to further reduce contamination. Hopefully I'm not too fast, guys. I'll take your question at the end. Aseptic technique enhancing components. So here we are also adding to the standards enhancing components. All this kind of slides just to show you that aseptic technique is doable and it's easy. Its elements very easy. It can be done with minimum resources that you have. Just by practicing it, just by giving the knowledge to your team, educate the staff about the importance of each single step of it, then you will get the best outcome of adhering to that practice. First, hand hygiene. As we know, hand decontamination prior to any procedure is a very huge step of any process that should be done, right? Because by the team working in direct contact with the patient or patient equipment, instruments, sterile field, if we minimize the microflora on the patient, on the staff hands, we will win the war. We will win the war, absolutely. Yeah, maximum reduction of skin microorganisms without damaging tissue is accomplished when healthcare providers decontaminating their hands by using antiseptic hand rub or antiseptic soap before operative procedures. In surgical areas, scrubbing should be performed before donning sterile gloves. Full stop. In surgical areas, scrubbing should be performed before donning the sterile gloves. Also, long nails, artificial nails, or fingernails, long fingernails, should not be worn. Artificial nails should not be worn by direct care providers, especially in healthcare patient, high-risk patient, like invasive care units, operating rooms, oncology, or neonates. Artificial nails, long nails, jewelries are not accepted, right? They can lead to a poor hand hygiene outcome. Okay, so avoid that. Next is skin antisepsis. Skin antisepsis or hand hygiene, these kind of components are shown here. Like if you cannot do it all, if you do some of these elements, it can lead to better aseptic technique outcome. So next to the skin antisepsis, it is used, we should use recommended antisepsis for each procedure type. So if we are going to do like clean procedure, we should use different soap than surgical procedure. Yeah, of course. Screening for contraindication of these antisepsis being used, such as allergies and age limitation. For example, you cannot use skin antisepsis for elderly people or for adults, just like the ones we use for infants, for example, in ICUs, right? So antiseptic agent should be used following what? The manufacturer recommendation, including ensuring that the skin is clean. Skin should be clean before placing the antiseptic. Yeah? Before placing the antiseptic, the skin should be clean, and antiseptic contact time, drying time should be allowed to get the maximum benefit of the antiseptic solution. Okay, these kind of points, if we get into it, we will have the maximum better outcome. Third is the single-use device, equipment, and supplies. All these kind of things are enhancing aseptic technique outcome. For example, other aseptic techniques practices involve using single-use devices and equipment, or maybe reusable device and equipment that have been properly processed and packaged. So we need to maintain packaging integrity. We need to double check reprocessing items and single-use items packaging. Packaging status. Are the package well kept in the store? Are they teared, torn, damaged? We need to double check to make sure, right? Personnel should maintain the sterile packaging and container integrity to ensure an intact seal and confirm that sterilization indicators inside the package are valuable, right? And make sure before use any sterile package, you should always inspect the package for signs of contamination, such as moisture, tears, or discoloration. Encourage your staff to inspect the package before opening it, before using it. Inspect the item. Items including solutions should be aseptically transferred to the sterile field, right? During transporting sterile fluids, we should maintain sterility of the transportation process. Next, when used for sterile procedure, disinfection pads or swabs or wipes, all these should be checked, checking the label of them, of the packaging outside, and check if there's written, if they are indicated as sterile. Because if it's not written, they don't consider to be sterile items, right? So always double check these wipes and pads, their sterility level, okay? I think finally is the environmental cleaning. So for environment, we should check two things: routine cleaning and post-exposure to spill in the environment cleanup. So routine cleaning and disinfection of the environment surfaces with an environmental protection agency approved hospital disinfectant or detergent, and the use of the efficacious germicidal agent for cleanup of blood or body fluid spills. So routine clean and cleaning also blood body fluid spills, both are examples of controlling the environment hygiene and to reduce the risk of contamination and microbial transmission in all patient care settings, right? So always in the environment, double check the routine clean effectiveness and post-spill cleanup procedure, okay? Also, use clean equipment and supplies, such as mops and water and clean clothes for environmental hygiene, right? Following by use of germicides to disinfect the area properly. Checklist for training and quality monitoring of operating room and all critical areas cleaning procedures are important training tool. And also it's important quality tool check. It's good to maintain checklists that follow up every day with cleaning activities, cleaning schedule have been done in the hospital or in the healthcare setting all, right? Especially in critical care areas. Conclusion. Aseptic technique can be performed in clinical practices areas that have adequate as well as limited resources, meaning it's a technique, it's steps. It doesn't require much as long as it is required awareness, right? And following the steps with crucially. Examples of asepsis that can reduce the potential risk of infection for the patient and healthcare personnel, including what? Cleaning of environment, practicing strictly hand hygiene, using of appropriate personal protective equipment, and the use of standards, routine cleaning, disinfection, and also sterilization practices for reusable items in healthcare settings. Okay? All healthcare workers should be cautious with their movement during aseptic technique procedures. Minimize their movement, minimize their field contamination as much possible, right? Barrier use as well, and practice to prevent breaks in aseptic technique. Also, one of the good practices is alerting others whenever you find the field is potentially contaminated or there is a contamination might be happened. notify your team, alert others that this item have been dropped, this contaminated gloves have been touched, sterile field, this gloves need to be changed, blah, 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 etc. This kind of alerting others is enhancing concept of good communication, team communication, which can lead for better patient outcome and patient safety too, right? Also, and finally, breaches in infection control practices and aseptic technique can contribute to cross-contamination. Yeah, we agree on that. So this may lead to transmission of infection between patients and environment contamination and to staff as well. These things should be reported and investigated by infection control team. And root cause analysis, maybe any kind of quality tool should be done in case of these things happened frequently, or maybe it can cause severe adverse outcomes, etc. So in this case, these kind of malpractices need to be reported. So thank you guys. I think I'm done with the first lecture. And I can take your questions if there are any. Let me check your chat, guys. Okay, good. Any questions? I'll give you 5 minutes, guys, to raise, type any question, if there is any. أهلا، في سؤال هنا يقول لك aseptic. There's a question here says aseptic versus antiseptic technique. Well, that's different. That's different from each other, because sepsis is contamination. Asepsis is removing of that contamination. So aseptic is the absence of microorganisms, right? Whereas antiseptic is the discouragement of microorganism growth. That's the difference. Thank you, everyone. We can move to the next lecture. Hopefully that was useful for you guys. Mm-mm. Okay. So next is PPEs, personal protective equipment. Our outline today is this lecture is very simple, guys. It doesn't have much complicated terminology or procedures or anything. It's just related to personal protective equipment definition, use indications, PPE types, donning and doffing sequence of the PPE, how to dispose and safety concept about PPEs. Finally, quality tools indicators related to PPE usage. Okay, so introduction. Healthcare personnel are exposed in hospitals to multiple health risks. Are we agree? According to the nature of their work, they may be exposed to infectious agents, chemical agents, materials, physical, mechanical, and other workplace hazards. So healthcare workers are exposing to so many risks, uh, so many risk agents, as we said. If we're going to mention the personal protective equipment definition, we will go straight forward with it is the equipment worn to protect the healthcare worker from acquiring infections and other hazards. Simple as that. Personal protective equipment may include items such as gloves, gowns, coverall, face mask, respiratories, goggles, rubber boots, rubber gloves, etc. Most importantly, when used properly, PPEs acts as a barrier. If they used properly and discard properly, they act as a barriers between infectious materials, such as viral and bacterial contamination on skin, mouth, nose, eyes, mucous membrane, wounds, drainage, any site. Okay? They can act as a very good barriers if they were used properly and discarded properly, as I mentioned. The barrier has the potential to block the transmission of contamination from the used instrument to the person or healthcare worker or CSSD staff or whatever. Okay? So this how the PPE acts to prevent cross-contamination to the healthcare worker from the patient or patient environment. And always, in most infection control lectures, we usually focus on the chain of infection, right? Okay, I have received a note that the slide is not showing. Let me see. الشاشة معلقة لم تنتقل إلى المحاضرة الجديدة. Wow. Okay. Sorry guys, give me 1 minute. Bismillah. Mm. gosh. How about now? Can anyone tell me how about now? Still? Oh, that's weird. I'll stop sharing, guys, and share again. Tamam? Tamam, alhamdulillah. Sorry, guys. So, personal protective equipment use, yeah? The outline, as I mentioned before. Introduction, how are healthcare personnel exposed to multi-health risks, infectious agents and chemical agents, and etc. And how is the use properly and discard properly of the PPEs are acting as a real barrier, between infection material and staff safety. Right? And here we are reaching the point that the PPE indications, why they are used. They should use to prevent skin, eye, mucous membrane, airways, and clothing exposure for the healthcare workers, right? So this is the indication of use. Also, they're used based on the degree and the risk of exposure in order to achieve a desired level of protection. Therefore, whenever you guys, especially nursing, doctors, team who is dealing directly with the patient service should maintain always themselves safe and their clothes, their mucous membrane, their eyes, nose, and hands, etc. Yeah, by using properly, selecting the type of PPEs that they need to use based on the degree of the risk of exposure and based on the type of service that they are going to provide, what they are expecting to be exposed to, based on the procedure. For example, if they are doing sectioning, what they should put on, surgical mask, of course, and face shield. What if they deal with isolated patient, droplet isolation patient, airborne patient, contact isolation patient, what type of PPEs they should select before entering patient area. All these indications are depending on patient status of infectious and the procedure that they are going to perform and the expected risk that they are going to explore to. Yeah, but at the end, the aim is protection, staff, environment, protection. Okay. What are the types of PPEs? Gloves, mask, N95 respirators, gowns, plastic aprons, eye protection, face shield. All these attires are suitable to protect the staff from infection. Let's take them one by one in a glaze. For example, gloves should be worn when there is a contact with what? Blood, body fluid, non-intact skin, or mucous membrane. By touching the surface equipment, for example, contaminated with body fluids. Like, what are the types of the gloves? There are sterile gloves and non-sterile gloves and heavy-duty gloves. Gloves material could be vinyl, latex, neutral. Gloves, what we should considering about glove purchasing when we are going to purchase gloves for our healthcare workers. We should check the good quality and the loose at rest, the thickness of the gloves, and also what is really convenient with the staff use, but not only convenience. We mainly focus on the safety, purpose, cost, effectiveness, and comfort at the end. Okay. Gowns and plastic aprons. Gowns and aprons should be worn if more extensive blood or body fluid splashing are likely to be happened during a decontamination, for example, or during any procedure like dealing with drain wounds, or an isolation precaution patient under contact precaution. This time we need to wear gowns, right? What type of gowns do we have? We have sterile gowns that are used in surgical suites, and we have the non-sterile gowns, such as the yellow gowns, right? What we should check during purchasing yellow gowns, what we should validate, what we should look for. We should look for the fluid resistant and the thickness of the material. And of course, we should maintain all sizes, adequacy number, all this kind of stuff. Yeah. Next is mask and respirators, such as N95 mask. Types of masks. We have standard surgical mask that protects the mouth and nose. And we have the respirator protection mask, which is N95 or N99 mask, which protect respiratory tract from airborne infection agents such as Mycobacterium tuberculosis. And lastly, we have a powered air purifying respirator, or we will call it shortcut poppers. Also the poppers to protect the airways of the staff from airborne infections. Surgical mask special recommendations. During the pandemic, we know that we have used surgical masks intensively, yeah, of course. But there are some malpractices, I could say, during using surgical masks, which can lead to cross-contamination or maybe staph infection. These things are like surgical masks should be worn with protective eye face wear if splashing or any aerosol generating procedure or any blood or body fluid is expected. Masks should fully cover the nose and mouth to prevent fluid penetration to your mucous membrane. Masks should be fit properly over the nose and the mouth. We can see oftenly people are using the mask only on their mouth, keeping their nose out, or putting the mask in another place. It should be covering the nose bridge until your mouth, under the mouth. Yeah. Mask should fit properly over the nose and mouth. Changing the mask sooner as the mask becomes wet, moist, torn. These are special recommendations for surgical mask use. Protective eye wear or face wear. Eye and face wear should be worn if required for compound protection to the eye and face from contamination, from any splashing that might occur. Okay, wash and disinfect visible soiled reusable face shield or protective eye wear prior to reuse. According to the hospital policy, according to the hospital disinfectant, we should use clean, disinfect this reusable protection tools after each use. Protective eyewear, face wear are not to be worn after leaving procedure area. Okay, because they consider to be contaminated, so they need to be discarded. Removed from the patient area zone and clean, disinfect, hanged there properly, and leave the area. Okay, never walk with them away. Donning and doffing. Effective use of PPE, as I said before, includes properly removing and disposing of the contaminated PPE to prevent exposing both healthcare workers and other people to infections. Because as we say in the beginning, the main aim for PPE is protection for the environment and the staff. So proper donning, proper doffing can enhance that goal, okay, to be achieved. Sequence of donning and sequence of doffing. So first we will start off donning PPEs. When you are aiming to put on your PPEs, first in the red line, what you need to do is hand hygiene, right? Hand hygiene is before any touching supplies. Before you touch any supply, any gloves box, any gowns bag, anything in the supply shelf, okay, you should do hand hygiene. Why? To protect the supplies from being contaminated if there is any germs on your hands, right? So first we need to perform hand hygiene, then we don. Then we don the gown, okay? After hand hygiene, we don the gown. So gown should be covering all the body from the neck to the knee, and tie the ties from the back properly, okay? Tie them in a manner that you can open them easily at the end, okay? Okay, then you don a surgical face mask. Place a surgical face mask on the nose and mouth chain, okay? Make sure you cover your chin. Then fit flexible nose piece on the nasal bridge side over your nose and secure the head with the ties, okay? Next, you don the goggles and face shield, if indicated, if your procedure is indicated, okay? Then you don the gloves at the end. Extend the gloves over the yellow gown cuffs. Don't keep that space open in your wrist. Don't keep your wrist exposed, okay? Cover the wrist with the end of the gloves with the start of the gown cuff, if that makes sense. Sequence of doffing the PPEs. In doffing concept, we remove the most contaminated part from our PPE. Why? Because we want to protect ourselves, our environment. So we will start with the most contaminated PPE. Which one will be the most? Is the gloves, of course. So first, you remove the gloves with the technique of skin-to-skin, glove-to-glove technique, which is the best I like, to minimize splashing germs from the gloves. Don't remove the gloves roughly or toughly or quickly. No, these germs can be floating away and stay on the environment around you. So just gently, skin to skin, glove to glove technique, remove your gloves. After removing the gloves, you can perform hand hygiene. It's missing here. Perform hand hygiene, because always before gloves donning and after gloves doffing, we do hand hygiene. Okay, next you remove your goggles or face shield if they were there. Okay, then you remove your gown. How you remove it? Unfasten the ties gently. Peel the gown from inside to outside. From the inner side, because your hand is clean now after you perform hand hygiene, your hands are clean. So you go inside your gown with the clean side that is nearest to your clothes, put your hand there and peel the gown gently away from your body, and then roll it up to minimize its size, discard it in the yellow bin or black bin according to your hospital policy. Perform hand hygiene. Then remove your surgical mask. Then perform your hand hygiene. What I want you to recognize here is that in doffing, we do hand hygiene 3 times, whereas in donning, we do hand hygiene for 1 time. Okay? And remember this note: before you touch your face or before you remove any PPE from your face, you usually perform hand hygiene. You usually perform hand hygiene. Okay? And remind your staff with this note too. So from the CDC, we have these well-known posters, which mentioned here, I know it's not that clear, but I think you are familiar with this here. Putting on, we start with the gown, after the hand hygiene, of course, then the mask or respirator, and you check, seal check, or you check your nasal bridge fitness. Here we add the goggles and face mask, face shield if it's indicated, and lastly the gloves. Okay, whereas in removing, we remove the first contaminated part, which is the gloves, then we do hand hygiene, right? And then your face shield, your goggles, whenever you have them. Next is the gown as peeling method right here. And then here you fold it, just like to minimize the size of it and to prevent having these gowns outside the waste bins over all the place. Just teach your staff to roll them and minimize their size so they can fit all inside the waste bin. Nothing of the edges of the gown is outside the bin and contaminated your environment. And you have to teach the housekeeping staff how to discard and how to deal with yellow gowns that they came out from the waste bin and etc. To avoid all these scenarios, just let them to roll it up and minimize size, and then never touch the in front, of course, side of the surgical mask or an N95 respirator. You always touch the ties like this, and then you throw it away and perform hand hygiene at the end. Okay. Quality indicator tools. So in order to make sure that the staff are adhering to PPE's implementation, adhering to standard precaution, we should maintain and double check these concepts that I will go through right now. First is sufficient and appropriate PPE are available in adequate amount, types, size, with the proper qualities, and ready and accessible to the healthcare workers, especially guys in critical care areas such as ER, ICU, NICU, PICU, isolation ward or isolation rooms. You as an infection control team, as an quality inspectors, should check your healthcare setting, your hospitals, your clinics, that the staff have adequate amount, all type of size, quality PPE are available for them to access and use, and they have been trained, and you have training checklists, and you have training schedule, and you have educational plans, which add all these kind of elements there to make sure that your staff are not wasting your resources. Because not understanding PPE concept may affect infection control outcome in two different ways. For example, your staff might use them improperly. For example, they use them extensively because they are afraid. They don't know about when to use and what to use and which is. So maybe they use over usage of PPEs, so they will cost you your inventory, they will cost your PPE consumption use, they will increase your budget and cost unnecessarily. But what if they understand when to use them, how to discard them? They will be confident and they will use them properly, and you will save costs, and things will be clear to everyone. Yeah. So, and supplies will not be used in improper way or wasted, or maybe sometimes they use less than indicated, so they harm themselves, they get exposed, and you will follow post exposure follow up with that staff. So making sure that the staff is really understanding PPE use is really crucial, guys. It's really crucial. Next is any deficiency of PPE item or poor quality of the PPEs, such as gown, gloves, anything, must be immediately escalated to the administration level. in order to protect the staff from acquiring infections. So if there is any PPE is not sufficient, with poor quality, very less repetition, you guys, the end users, enhance them, give them the ability, enable them to report to you guys that this item is not proper, this gloves is torn while I'm in the middle of the procedure, and you guys you should help them to protect themselves and provide them with something good. Regarding reusable PPE, because during the pandemic and the minimum resources of the N95 mask, some countries, some hospitals initiated N95 mask reuse and extend use policies. And I hope you check your hospital setting and check if these kind of policies are available. But make sure that you follow the manufacturer recommendations and instructions, because they must be followed for safe reuse of PPE, such as reuse N95 mask, eye goggles, etc., reusable heavy-duty gloves and boots. These kind of items should be limited for individuals only, and whenever be extended, they should be clean, disinfection after each use, and allowed to dry well. Okay. If we are going to check the safety concept check, we should go through a PPE should be used with extreme safety, right? In order to avoid risk of acquiring infection and contamination, such as keep gloved hand away from your face. Make this as a practice. Avoid touching and adjusting other PPEs while you have gloves on your hand, because you don't know these gloves are contaminated or not, and you might contaminate the whole supply stock. Remove gloves if they are torn or insufficient. Perform hand hygiene before donning new gloves again. Limit the surfaces and item to be touched if you are fully PPE'd with PPEs. Before leaving the procedure patient area, PPE must be removed, discarded safely and properly. Okay, so the summary for PPE lecture is this. Lecture is based on evidence-based recommendation, just to let you know, on the core component of infection prevention and control programs that are required to be placed in healthcare facilities level. Also, application of strict infection control. This is something we should always remember. Principles and practices in healthcare activities is necessary to achieve safety and best health outcome for the patient, staff, and visitors. Hopefully this was smooth and basic. Any questions, guys? I think this is really basic. Thank you guys for listening. Thank you so much. Good. Thank you, Majid. طيب ناخذ 15 دقيقة. Can we go with 15 minutes, guys, as a break for me and you? And I'll see you 4:30. I'll see you 4:30, guys, okay? Thank you very much. مرحبا جميعا. طيب بسم الله again. Good evening everyone. Today this is the third lecture. We are going to cover infection control risk assessment or risk management. Outline for today will be an overview of the risk management and infection prevention and how this risk management is correlated to infection control program, infection control annual risk assessment plan. Also, we're going to cover risk factors for infection transmission and risks association factors that might be contributed also. And finally, risk controlling elements. At the end, we should know how to control all these risks that we are going to go through. Basic principles about risk management and infection control field. So according to the CDC, 1 in 25 hospitalized patients will get an infection because of the care they receive. So it is estimated that 75,000 patients will die each year from healthcare service. Imagine, that's a huge number. From this studies, from this point of view, infection control risk management, risk assessment, annual risk plan has been implemented and determined and start to be one of the crucial, essential elements, topics to be discussed in infection control committee, in one of the infection control policies, one of the infection control standards, which should be implemented in any healthcare settings. So understanding the risk factor that facilitate the transmission of infection agents is important for preventing the spread. Because if you know your enemy, you can protect yourself from your enemy. But if you don't know your enemy, you cannot protect yourself from it. And these organisms are various and inhabiting and using the healthcare environment as a reservoir to growth, to produce, to get antimicrobial resistance characteristics, and etc. Okay, so we have to bear our mind to all the risks that could be possibly, potentially happened in the hospitals. The recognition of the risk factors supports to determine the need of additional interventions when patients are, for example, colonized or infected with these organisms and entering the healthcare facilities. So from here, we know the importance of the risk management. This all understanding is also a key for the healthcare associated infection surveillance data, because we are knowing the source of infection, we are collecting data, we have graphs, we have statistics, we have correlated factors, we have risk factors, we have all this kind of knowledge that can lead us to maintain, contain, control the sources. Yeah, do you agree with me? So that adjusts for certain infection risks and are used in infection rate detection, of course. We can use them as a KPIs as well. So there are multi tools that we can invest in order to maintain and manage the risk in hospitals. This knowledge, again, then aids the development and implementation of intervention to mitigate the transmission of infectious agents in the hospitals. Again, a model used to understand the infectious disease process is often called the chain of infection. So if we understand genuinely the chain of infection, then we can break this chain in any step of it by interfere with any kind of infection prevention measure. Then we can lead with a succeed. Understanding the component of the chain of infection and their relationship to each other is critical to determine the risk of infection and needed interventions to interpret the disease process to prevent or mitigate transmission. This allows staff to identify and protect patients and take precautions to protect themselves too. So as I said, the core component of any risk management and infection control is the infection control program. It is the most important component of safe, high quality health service delivery. That's the core component of the infection prevention and control program. It is implemented in the hospital. Implementation of the program is critical, not only to prevent healthcare-associated infections, but also to prepare for responding for communicable disease disasters, crises, etc. Infection control program could help in this preparation too. So trained team, dedicated persons should be in place in each acute healthcare facility for the purpose of preventing healthcare-associated infections and combating antimicrobial resistance through infection prevention and control good practices. Okay. The purpose of the program is to eliminate the risk of healthcare-associated infections and work-related infections within the healthcare facility. But how? Through what? Through the implementation of established guidelines and policies. Hospital-acquired infections are one of the most common complications or adverse events affecting patient and healthcare workers. Right? For example, if a healthcare worker is dealing with infected patient, he will not feel that comfort as he's dealing with a non-infectious patient. That's the thing. So an adverse of getting a patient's infection is even impacting on the staff convenience, of course. The result in increased morbidity and mortality and impact on the capacity of health system to function effectively. Of course, the program is based on current scientific knowledge, reference practices, guidelines, and applicable national law and regulations. Moving from the program to the annual plan, infection control annual plan. As I said earlier, infection control program and annual plan all are covering the risk management, risk assessment and infection control. So the annual plan is based on infection control risk assessment. So from your risk assessment to the facility, you can create your annual plan. Why annual plan? Because infection control departments are anticipating in many departments. It interferes, for example, with pharmacy practices or pharmacy staff, or pharmacy services, for example. It interferes with catering. It oversees CSSD staff and processing. It oversees nursing compliance for hand hygiene, physicians compliance for, isolation precaution PPEs. Infection control department are anticipating and participating in many fields. So during the year, if the department has no selective prioritized risks that should focus on during that year, we will reach the end of the year without any outcome, without any significant outcome, right? If you agree with me. Therefore, we should, from our risk assessment, we create annual plan. We start from January with our goals, our objectives, tools, etc. I will come through that in the next slides. Ending to December of the year, finally monitor the whole process during the year, seeing how we are going, how we are proceeding, what we are achieving, okay? And from there, we can know our weakness points, our strength point, what we need to support the process to be accomplished and successful, etc. Okay, so again, the annual plan is based on the infection control risk assessment. As an abbreviation, we say ICRA. Okay, this ICRA is focusing on addresses, processes, procedures, resources, devices that might be identified by infection control practitioners to be associated with healthcare associated infections, any risk factor that infection control team could view it as a risk in this facility should be added in this plan. Okay, right, it's just like brainstorming, so you will add everything in there and then you will customize, prioritize, arrange the whole sheet in a proper way so you can follow it through the year. Annual plan is a written risk-based document with goals and measurable objectives. You cannot add something that cannot be measured. Okay, measurable objectives, strategies, and evaluation methods. Whereas the risk assessment is a term that is used to describe the overall process or the method to identify, evaluate the risk factors that have been potential to cause a harm to the patient, staff, and visitor environment. Okay, that's the difference. Why to perform an annual risk assessment? As I say, infection control is interpreting every else of department, all the departments, interferes all kind of practices to make sure that they deliver the best, safest practice to the patient. So this helps to focus activities on essential tasks to reduce critical infection control risks, to improve patient safety, improve staff safety, improve efficiency, identify training issues, training gaps, training topics that need to be more, staff need to be more about and need to be aware about, understanding of disease transmission and prevention, and implementing a new intervention whenever indicated. Right? If we are going to talk about emerging diseases, re-emerging diseases, sometimes the intervention are updated. Yeah. So we need this annual risk assessment based on the updated risks that we are facing geographically, publicly, our location, our population, what are the population that we are served, what kind of scope of service that we are doing in the facility. Based on these factors, we can dedicate what are the risk factors that we might face. Steps involved in risk assessments. So there are plenty of steps. I'll go through them intensively, actually, because this is a very interesting topic. First step is annual infection prevention program review. So first thing first, we need to analyze, review the data that we have from the last year, which is the basis of annual risk assessment. Sometimes you have some risks from the previous year that is not accomplished and not went through successful story. So you need to add these missing points that missed achievement last year to your new year plan and try to fix it this year. Okay. Step number 2, risk assessment tool. It is a scoring tool numeric scoring system based upon probability of the event to be occurring. So we give the risk a score of its probability to be happened, okay? Because there are several risks, yeah? Some, they might happen 60% of the year. Some, they might happen 20% of the year. So we need to give them a numeric scoring system. Next, multiply the rate for each risk in the area of probability, impact, and organization preparedness for that risk. This will be our risk score. So our risk score will be three things divided by, multiplied by each other. The risk probability, risk impact, and the organization preparedness for that risk. This will be your risk score. And then the rank risk by total score to help identify priorities. So from your risk score, you will prioritize your risks, sort them in order. Prioritize are used in the development of infection prevention and control plan. So widely and in a wide scale in the hospitals, infection prevention control annual plan. From there, we get the risk assessment. From the risk assessment, we prioritize our priority things to be focused on, what are our red flags, etc. From the priorities, we make our plan. The plan mainly focuses on goals, objectives, strategies, and evaluation. I'll give some examples. This is the risk assessment sheet, annual risk assessment sheet. The hospital name, region, year, bed capacity, how the hospital, how many intensive care units bed do you have there? All this kind of risk is managed, is documented. You will have here probability of occurrence of the risk, never 0, rare 1, maybe 2, etc. And then you will multiply these numbers, and then at the end, this is your score. In this sheet, the highest score is this one, which is, for example, lack of airborne precautions. It's actually very, very, very useful practice and very nice one to do it like with the whole infection control team department. The annual infection control plan looks like this in written format. The plan includes goals for patient safety. For example, one of our goals to patient safety is implementing standard precautions or transmission-based precautions or healthcare bundles or patient family education. These are goals for patient safety. So we want to add them in the annual risk assessment plan for us. For example, if the risk was isolation activity, so the potential risk will be the lack of airborne precaution. That's the risk. After our risk assessment at the facility, we find that there is a lack of airborne precaution implementation and a lack of airborne rooms in the facility too. There is not enough adequate number. So the goal is to provide adequate isolation facility rooms, right? According to the risk assessment outcome. What is the strategy, the method? Strategy and method. Send a request, follow this request for the negative pressure room implementation. Purchase a HEPA filter, for example. Maybe you will utilize a single room with a HEPA filter temporary until the negative pressure room are available, etc. Second, make a clear guideline or policy to manage patient with airborne precaution or infections until the availability of the missing part or the potential risk that you are addressing. So make plan B. This is the strategy. Strategy is that you do efforts to fix the thing, and plan B until the things get fixed. Yes? Okay. Responsible person. You should dedicate and nominate a person who should handle this issue, so we know which is which and who is responsible for what and etc. for example, here will be the healthcare, the higher administration, infection control to follow up. And that's, yeah. And also you should clarify the time frame from January 1 until December 31, the year, a specific time. If it's something that is really big, needs construction, renovation, needs a very big budget, you should give time. You should give logic time to these goals. You have 1 year. You have a plan for 1 year, and you measure and weight. Measure and weight the consequences, the circumstances, your hospital budget, financial things, communication, etc. These kind of boundaries and challenges. Put it in your mind while you are creating your risk assessment. Monitoring and evaluation. Of course, if you are starting any what do you call this, plan, any strategy, you should monitor and evaluate it, so you know where are you reach now. So assessment of the need for more airborne rooms, depending on the volume of patient that needs an airborne isolation to be admitted in the hospital. Or based from this evaluation, you can follow up your requests. Next, the plan includes goals. If the plan is, for example, include goals for healthcare workers, not for patient safety. No, now we are talking about another example, healthcare worker safety. For example, staff immunization, post-exposure management, or healthcare worker education. We need to review the annual plan and verify these components. Is the healthcare worker immunized? Post-exposure management, education, as I said, mention clearly in the plan details that you need, the objectives that you are targeted, the activities written that you want to do, KPIs that relevant to this point. All these need to be monitored, evaluate, follow up, documented, written, and clear. If there is any risk assessment for a healthcare safety data, post-exposure, for example, management related to incident report, non-sufficient, for example, system follow-up for post-exposure staff, number of needle stick injuries reported in the year, for example, 2022. These things need to be clearly mentioned in the annual risk assessment plan, and based on those you can create your objective, your strategy, methodology, and responsible person, time frame, and monitoring. So in this example, we took a staff safety example, declining influenza vaccination covering among healthcare workers. This is a risk factor. This is a potential risk. If it's not fixed, we might have an influenza outbreak in the hospital. Okay, so the goal is to have 100% influenza vaccination coverage among targeted healthcare workers. The strategy will be 4 points: education, awareness to the staff about importance of influenza vaccination, availability, adequate vaccines and relative supplies, explore, add reasons for declining rates. I mean, if you have any staff, for example, that is not interested to have the vaccine, they should write a declaration form that they are knowing about the consequences, they are aware about the flu infection consequences, and it might increase staff absence, it might increase, infection rate in the ward, this kind of things that the staff should admit in a letter. Disciplinary procedures for non-compliant staff with the vaccine policy. Who is the responsible person? Will be the employee health team, infection control team. The time frame from Jan to December. And in this case, it might be, for example, the flu season, of course. Monitoring, evaluating, vaccination census, coverage rate, compliance in each quarter. Okay. The plan include matrix of required changes and targets and goals to measure the achieved processed activities. Okay, so annual plan goals progress tracker. There is a tracker sheet or matrix that we can write our risks here, and then if we consider them as a KPIs and follow up them in each quarter, quarter 1, 2, and 3, what was the progress of these factors. Risk factors for infection transmission. Of course, if we are going to create the risk assessment, we should, as I say in the beginning, be familiar with the chain of infection. Okay, the chain of infection consists of, as you can see, 6 steps, which can be broke by simple interventions. Okay, I'll go with you through them intensively, actually, because I like this sheet. It's very, very useful, and it has all the things that we need to talk about. The infection starts with infectious agents, of course. It starts with infectious agents, such as bacteria, fungi, parasites, virus, whatever kind of microorganism that can initiate the chain of infection. The infectious agent, when it's created, it needs to have a reservoir to live in, to accommodate, to multiply, to produce more of it in it. What would be that? It can be any dirty service equipment. It can be in people, hands. It can be in the water, and the food, soil, animals, insects. These are the reservoirs for the pathogens. After the reservoir, they need to have a portal of exit from this reservoir, so they can spread and have a transmission mode, so they can go to the portal of entry. So the portal of exit will be any open wounds, any open skin, aerosols, droplets, for example. Those are, secretions, these kind of exit ports or portal of exits. Next, they need transmission of mode of transmission, for example, contact, droplet, airborne, direct, indirect, inhalation, ingestion. What type of transmission mode suits the organism and its ability to be transferred? It will be used to be transferred. Now, after the transmission can lead to the entry to the susceptible host or to the person who will be infected. The portal of entry, it could be any broken skin again, respiratory tract, mucous membrane, catheters, and tubes. Okay, so if these germs can enter susceptible hosts, could be any person, especially immunocompromised, elderly, infants, post-surgery persons. Those are high risk patients whom can accommodate infections immediately and easily. Okay, how to prevent each step in this chain? To prevent infectious agents to be multiplied, to be recognized, to be a risk factor, okay, to be abundance, and until they can be a risk factor. Early diagnosis and early treatment is a very good way to break this chain here. Also, antimicrobial stewardship to avoid having AMRs, MDROs, multi-drug resistance, vaccination, healthy lifestyle. All these kind of things could prevent production of any microorganisms because we are minimizing their ability to live and multiply by these practices. And here we can train the chain to reach to break the chain for these germs to reach any reservoir, to live in any reservoir by cleaning, disinfection, sterilization, infection prevention policy implementation, pest control, because we have here insects. These kind of measures could break the chain, not leading to a reservoir level. In order to prevent the porter of exit, of course, if you can see here, the three down elements, which is portal of exit, mode of transmission, portal of entry, almost having the same measures: hand hygiene, PPE, control aerosols, respiratory technique, cough etiquette, waste management, disposal. Almost they are the same to protect these three steps. Whereas susceptible host immunization, like boosting our immunity system, healthy food, as I said, treatment of underlying disease, chronic diseases, health insurance, patient education, awareness, increasing patient and their family awareness is crucial to break the chain infection in this side. Risk-associated factors. The risk of healthcare-associated infections during patient care is related to the mode of transmission of these infection agents, the type of the patient care activity which is conducted, and also including medications being received or procedures being performed, or compliance with recommended practices or non-compliance, also the cleanness of the environment, also the training, education, awareness, and experience of the healthcare personnel, staffing ratio, as well as the core value here, population immunity, and patient underlying host deficiency. Risk associated factors too. Some patient factors that increase the risk of transmission within various healthcare settings and in patient-owned environment, including immunocompressive disease and disorders, malignant disorders, poor nutrition status, age, diabetes, pregnancy, travel history, occupational health, and contact with certain pets and animals, burns, traumas. All these factors can increase the association of risk in any population, actually. Medical interventions have also been shown to have an influence on the patient risk of infectious, including the presence of invasive devices, because as we know, invasive devices increase the opportunity of the patient to get infected. Placement in the intensive care unit, exposure to antibiotics for a long time, immunocompressive therapy, linked hospitalization, staff ratio again, non-trained staff, also increased number of health personnel examinations and procedures, of course, can lead to risk association in humans. More recently, research has demonstrated that by strict compliance with the recommended bundles, recommendation practices of management, specific devices, surgical care, and risk of infection to be reduced, actually dramatically reduced the patient of increasing the risk of infection if these recommended measures has not strictly followed 100% of the time. This will show a dramatic increase in healthcare-associated infection. Healthcare personnel, employees, medical staff, students, volunteers are at risk also for exposure to any microorganisms in the healthcare facility. Also, even serving at home setting, for example, home care team during home care activities. To reduce the risk, care provider must follow recommended practices by infection control, of course. The goal of NHSN are to provide an estimate of HAIs, identify and provide the data trends That's why we are using surveillance. Why? Because we want to know the trends, the trend microorganism, the trend infection, the trend the risk factor associated with any high rates that can lead that can take our attention to that factor, and make sure to control that risk as soon as we recognize it, and help members facility to develop surveillance and analysis method to help identify patient safety problems and encourage promote intervention to improve outcomes. Now, the risk controlling elements, I think that's the end slide. Actually, we have went through many good, brilliant ideas to break the chain of infection and how to control the risk of infection. But here we can summarize them in standard and expand infection control program. For example, isolation, precaution, follow-up, aseptic technique, follow-up, hand hygiene program, implementation, respiratory protection program in healthcare workers or in patient, triaging, isolation, rooms, availability, all this kind of things. Also, healthcare-associated infection surveillance program, including prevention bundle like central line prevention, urinary tract, urinary catheter, ventilator, and NDRO bundle, active screening and outbreak management program. Moreover, AMR program اللي هو antimicrobial resistant program, activation, employee health program, post-exposure management, follow-up, etc. Waste management, housekeeping program too, training education program, and services most of the time. I think that's the end. Thank you very much, guys. Do we have any question? Thank you, Bilal. Thank you, Abdul Majid. Was it clear? Hopefully it was clear for you guys. Yeah, thanks. Good. Shall I give you 10 minutes or move on to the next lecture? What do you prefer? أهلا وسهلا جواهر. You're welcome. 5 minutes, Johara? Yeah. Okay. 5 minutes break, guys. And then I'll see you inshallah. Ali, I think we will post it in YouTube, the material, if you want to get it from there. Thanks. Bismillah. Hello, everyone. Good evening. Okay, we are back from our 5 minutes break. So this is my last lecture today with you guys, which is related to education to visitors and patients about role of infection control. This is very simple guide, because when you talk about visitors, patients, you're not talking about type of healthcare worker. You never know their educational background. You never know their languageal barriers. You never know what is their experience in life. So if we are going to talk about visitors and patients education, we're going to minimize the level of knowledge and the level of terminology and the level of complicatedness words that we should mention to them to the minimum level in order to deliver the best information that they need, the best knowledge that they which can help them to prevent infection by themselves. I'm trying to move, but yeah, simple as that. The outline has the goals of this training and objectives, responsibilities for this training and educational sessions, educational permit. We should be familiar with that for ourselves and for the patients, visitors too. What should the patients and visitors know? What they should know about, what you should enhance their knowledge about. Allahu Akbar. So the goals and training objectives, patient and their families play an important role in infection prevention. Do you agree with me? Let me check your chat. Do you agree with me? Hmm? Yeah, of course. Why? Because families, they are the watchers sometimes. They are the visitors sometimes. They are the caretakers sometimes, especially in home care and etc. So patients and their families play an important role in infection prevention. As an infection control practitioners, as an quality inspectors, take your time to educate them. Okay, be humble and simplify the information to them. Speak with their own language. Go down to their level. Okay, and be patient with them. Educate them on the infection prevention basics and how to help them to feel comfortable asking you questions and voicing concerns if they have any for you or for any healthcare professional in the facility. Okay, so this is the window that we should open between us and the patient and their families. Infection prevention and control department should provide education on infection control for patients, families, and visitors. Okay, if there is any document that is designed and formalized to help in education of these patients and visitors, we should go through that, such as plans, posters, brochures, etc. The educational program designed for visitors and patients should be done by the infection control team if they are valid and having relevant information. They should add all relevant information in this educational program in order to deliver this information to the patient and their families. Patient program should have minimally standard precaution, isolation service and practices, post-discharge wound care for preventing surgical site infection. Okay, and of course, standard precaution that involves hand hygiene, PPEs, health environment. Clean environment, clean equipment, medical supplies, cough etiquette, clean linen. All this falls under standard precautions. So, patient should be educated on standard precautions and what is included in that, isolation services and practices, and post-discharge wound care for preventing surgical site infection. And as a staff, randomly ask any visitor, any watcher about the isolation ward, and the isolation ward about how they receive precaution knowledge during their stay in the hospital with the infected family member. Before they being allowed to a visit or to be a watcher, they should have a session, an educational session by the infection control team or the head nurse of the isolation ward, how to do proper isolation precaution. Basics, okay? If so, ask them about these precautions. Let them tell you the story. Let them tell you what they know, because they might say yes, but they don't know really what is sufficient information for them, what is really protecting them. They might not know. So ask them to demonstrate for you, for example, how to don N95 mask or surgical mask, how to doff gloves, for example. Ask them to demonstrate for you what they do understand about infection prevention basics. Okay. Responsibilities. Infection prevention team must ensure the availability of the following, all what I'm going to say: bilingual infection prevention and control health education awareness material must be designed format to help the education process of the patient and visitor, such as posters, brochures, pamphlets, booklets, leaflets, all these kind of things, containing the information easily written and understandable to help them also display. If we can add pictures, display pictures, this will be an added value. The educational material must be posted, available in all patient care areas and waiting areas, entrance, of course, and accessible for them, readable, okay, with very clear handwriting, clear font, nice colors, eye catch, etc. We should focus on hand hygiene, cough etiquette, COVID, MERS education, material things. Okay, these kind of things, if we enhance this knowledge in the patient, visitors, patient family, we are minimizing the risk in the community. We are minimizing in the risk in the hospital as well. Okay. In the patient care areas, units, education provided to patients and visitors must be structured and documented in patient files. An infection control team who is attending with me this lecture, they know what I'm talking about. Each time you have an infected patient who is admitted in isolation area, when the infection control staff educate the family member or the watcher of the patient, if possible, they should document in patient file that this family have been educated about hand hygiene, standard precaution, isolation precaution, cough etiquette, MERS-CoV, this kind of stuff, okay? For example, hemodialysis patient must receive an education. He's a must receive an education about personal hygiene, importance of a frequent hand hygiene, care of central venous catheter at home, and how to take a shower with intact CVC. Of course, and this data should be documented in patient file. Okay. Now, visitors are educated on precautions to be taken while being in the surrounding of a patient who is infected. Of course, the importance of hand hygiene and isolation precaution required in case of isolation precaution. They should be aware about all these things. Education must be provided Oh my God, 1 minute. You can't see the, guys, you're not seeing the, oh God, risk factors. 1 minute, I'll disconnect, I'll stop sharing, and maybe share again, or what? Let's see, share. That's weird. I'm trying, guys, to reconnect the screen. I think, oh God, are you okay now? Can you see what is presenting? اوكي appear now. Thank you علي. Oh my God, يعني انتوا ما شفتوا اللي انا قلته اول. طيب. Sorry guys. I have no idea. انه ما كنتوا تشوفون. I think it's okay now, huh? Okay, so I will carry on. We reached responsibilities here. Yeah, we reached that visitors are educated on precautions to be taken while being in the surrounding of a patient, especially if this patient is infected or non-infected. They should know the importance of hand hygiene, isolation precaution required in case of isolated patient is admitted from their members, family members. Education must be provided on how to don and doff PPEs, as I mentioned, and to perform hand hygiene correctly before entering an isolation room and after leaving it. Education must also include the importance of not visiting patients under isolation precaution if possible, for their safety, of course. If they could delay the visit until the active disease is resumed, is done, is declined, then they could visit if possible. So always give these options to the visitors, give these options to the family members, because they might not know the potential risk that they are facing. So in education, in generally, we should know the educational permit, I believe. Education is separate in two parts, active and passive. And the more you go with the passive, the less benefit you got. For example, lectures has 5% benefit in education because it's passive, reading, audiovisual, demonstration. Until here, we can consider this as passive. And here, we can consider this as active learning methods. So learning or teaching methodology to the patients and the visitors of families is important. I believe you should use discussion and practice doing. These 2 points is very efficient with the patient education, because they want to know, they don't have medical background, they don't understand what we are talking about. However, open discussion with them about the potential risk that they might have surround them and patient zone, and how the family member could take that risk to home or to their cars or to their kids, okay, while visiting an infected family member. This discussion is kind of enlightenment and increase patients' families' awareness about the risks that they have no idea, they never studied about it. Okay. And also practice doing it. For example, if you teach them how to do hand hygiene for 20 to 30 seconds, or hand wash for 40 to 60 seconds, let them demonstrate for you what you have taught them back. Try to make a fun session education with them. Make it fun, make it simple, be humble. I tried it by myself. The more you be humble with the patient family, the more you will impact on them, the more you will be remarkable. Not you, the information you give will be remarkable. They will never forget what you ever said. Okay. And they will follow it actually. So discussion, practice doing, I prefer this with all types of educations that I have done actually, even with healthcare workers. Adults, they prefer these methods, okay? And adult learning techniques. Right. What your patients, visitors should know. I tried to list 10 to 11, I think, things that we should probably focus on to deliver this message to our patients, visitors, and their families. First, to be aware about HAIs. Okay, let them be aware about healthcare associated infections, and a patient can get any of them while receiving medical care. And these infections are often preventable. They are preventable. How? By implementing infection control measures. So they are, I think the most different between infection and disease is disease sometimes diseases cannot be prevented, whereas infection is most of the time preventable. That's why we don't have to have high rates of infections. Okay. Hopefully everyone can see what I'm posting. ما شفنا اللي قلتي أو ما سمعنا اللي قلتي. عبد الرزاق. عبد الرزاق, can you see my slide now? لأني أنا أستطرد كثير. I'm not reading from the slides. So يمكن اللي أقوله it's not written. Yeah? Okay, thank you, عبد المجيد. Right. So infections are often preventable. Therefore, we should give the education that focus. We should give the education that value, because we could help to decrease infection rates through patient family and visitors. No matter where a patient is, in a hospital or a long-term care facility or outpatient surgery center or dialysis center or anywhere, the risk is there of infection. Okay, so they have to know this information. Second, feel empowered. Patients need to feel empowered, enabled to speak up for their care. For example, they should never feel shy to ask for more information, ask for more details about the infectious status, or even they should never feel shy by asking the healthcare worker to perform hand hygiene before touching them. They can remind healthcare worker to perform hand hygiene. They have the right to do so. Okay. Third, know to clean their hands often. They have to know that hand hygiene is the most important way to help to prevent infections. Hand hygiene is crucial. Hand hygiene is important. Okay? Right. الترقيم غلط, معلش. Then be prepared to ask questions about their medications. Be patient when they ask you about medication, especially antibiotics. What I care about as an infection preventionist is antibiotic course. When a patient has to go through an antibiotic course, we should teach the patient the importance of following the duration, the dose of the antibiotic. Why? To avoid promotion of antimicrobial resistant organisms. Because as we know, or no, let's read from the slides. Why, especially if antibiotics are being prescribed? Because taking antibiotic the wrong way can promote antibiotic resistance. It's essential that your patient know what their medications are for, how to take them, and how long they should take them. This is necessary. Okay. Next, how to practice good post-surgical care. How? Patient who how to care for their wound after leaving the healthcare facility post-surgery, for example. How to change their dressing using appropriate hand hygiene, using clean supplies to clean their wounds. Patients need to understand the importance of their own hand hygiene as well. Next, understand how to care for their devices, if any. Advise your patient to ask if their device, for example, any catheters, is necessary or they should be removed. If your patient is sent home with a device, teach them how to take care of the site of the device so they won't develop any infections. Next, have a plan to stay up to date with their vaccinations. Ask them about their vaccination status, right? Vaccination can prevent the suffering and cost. Therefore, can prevent, flu, pneumonia, HPV, hepatitis B, prolonged stay, morbidity and mortality as well. Next, they can always ask to speak with the infection control staff, because the infection control staff may have the best knowledge about the infectious status of this patient if he is infected. For example, isolation duration, isolation discontinuous of isolation precaution. For example, any sample that need to be sent if the patient is acquiring any questions about it, why you send this sputum sample for me today, why you ask for urine sample from infection control side. We should explain to the patient the risk that might be occur and around of the patient, so the family get alert and be cautious about it. And finally, remember, by educating your patients, you can help stop the spread of infection. Take this note with you today. Thank you very much, guys. I think this is the last slide. I wish it was a useful sessions for you. And if you have to ask any questions, if you want to, أهلا وسهلا, you're welcome. Let me call my next friend. You're mostly welcome, Abdul Majid. أهلا وسهلا, Ali. Thank you. طيب يا جماعة, نستنى 10 دقايق. Can we wait 10 minutes until the next instructor join us? Nice to see you all today here. Thanks for your attendance and listening. Hopefully you enjoy all what I have mentioned. And I'll talk to you tomorrow, inshallah, next sessions. Thank you guys very much. So give us 10 minutes and then the next doctor will be in soon. You can take a short break. Thank you. Bye-bye now.
السلام عليكم. Hello everybody. ازيكم عاملين ايه؟ اهلا اهلا عبد المجيد، فارس، علي، اهلا وسهلا بيكم. يا رب دايما. منورين منورين كلكم. ريان، عبد الرزاق، ابتسام، تهاني، منيح منيح يا عبد الرزاق. اهلا يا نون. مركزين نبدأ ونسأل على طول. طيب طبعا أول حاجة عايزين، اللي عايزة أعرفكم بنفسي يبقى محمد، radiologist, certified professional of healthcare quality, master of business administration. We will talk more about the patient safety, but with infection control. يعني هنتكلم أكتر حاجة عن علاقة سلامة المرضى مع الانفكشن كنترول. طبعا عايزة أسأل سؤال الأول وأعرف هل في علاقة بإن احنا يبقى عندنا ثقافة سلامة المرضى أو السلامة نفسها كلها والانفكشن كنترول؟ لا لا، أنا لسه ما بدأتش يا بشاير، أنا بسأل بس، لسه يا دوب بنبتدي حضرتك. Yes, thank you عبد المجيد. What is the relation between patient or culture of safety with infection control? Yes, what is the relation يا عبد المجيد? Like what? When we have culture of safety, yeah. Ali, yes, yes, yes. Thank you, Abdul Majid. My questions is, there is relationship between culture of safety with infection control, and what is the relation between of them? You are excellent, Abdul Majid. ثقافة سلامة المرضى هتخلينا إن إحنا نحد من انتشار العدوى في المنظمة الصحية بتاعتنا أو المؤسسة الصحية. When we have a culture of safety, we can prevent all infection control in our organization. تمام؟ It's okay, Ali? Thank you. Then we will start. The culture of safety impact on improvement in infection prevention. It will impact in how to improve infection prevention. And here it's important to be prevent. The first thing we will catch and we will search, it's to prevent any infection. أفضل حاجة إن إحنا ندور عليها أو نشوفها إن إحنا الأول نعمل prevent، إن إحنا نمنع، يبقى في عوامل تمنع العدوى نفسها. أفضل من إن إحنا نقللها. الأول ندور على عوامل ومبادئ واستراتيجيات إن إحنا نقلل، إن إحنا نكافح العدوى. تمام. The culture of safety impact on improvement in infection control and infection prevention. A patient safety culture make us know how to reduce the spread of infection in the healthcare organization. ده اللي احنا قلنا عليه، ان احنا سلامة المرضى بتخلينا نحد من انتشار العدوى في المنظمة الصحية بتاعتنا. We have two organizations in infection prevention. The World Health Organization, CDC is the Center of Disease Control and Prevention. Infection associated with healthcare center affect 7 to 10 every 100 hospitalized patient in high income and low and middle income countries respectively. العدوى بتنتشر وبتأثر من 7 ل10 مستشفى، من 7 ل10 مريض من كل 100 مريض في المستشفى، وخاصة في البلاد المنخفضة في البلاد المنخفضة أو متوسطة الدخل أو مرتفعة الدخل. الأول المنتشر يبقى العدوى المرتبطة بالمستشفيات أو الهيلث كير أورجانيزيشن بتأثر من 7 ل10 مريض من كل 100 مريض، وده رقم كبير جدا. فعشان كده محتاجين إن احنا ننشر ثقافة سلامة المرضى. The application of quality and safety culture is one of the top priority of health establishment because it plays a major role in the decrease in the incidence of infectious disease. عشان كده بنقول إن ثقافة الجودة والسلامة دي أولويات المؤسسات الصحية، لأنه دور رئيسي إن هو يقلل لنا من الأمراض المعدية وخاصة الأمراض اللي بتتعلق بالمستشفيات. Here, the hospital national patient safety goals. We will talk later about the all national patient safety goals. هنتكلم بعد كده في محاضرة كاملة عن أهداف السلامة للمستشفى. Introduction. Why we need to understand the relationship between safety culture, infection prevention and control, and healthcare associated infections. خاصة الأمراض المرتبطة بالرعاية الصحية. Who can tell me what I mean healthcare associated infections? ايه العدوى اللي بتكون مرتبطة بالمستشفيات زي ايه مثلا؟ دكتورة نورة ما شاء الله شرحت حاجات كتير، فممكن أعرف ايه أنواع العدوى اللي ممكن تبقى في المستشفيات، أو يكون المريض داخل كويس مثلا بمرض معين ويجيله عدوى معينة من المستشفى بعد دخوله للمستشفى. like what؟ what I mean and اوكي معلش انا مش شايفة الشات. عدوى جراحة UTI. yes excellent علي. انتقال مرض معين. yeah يعني زي ايه مثلا الامراض المعينه اللي حضرتك بتقول عليها يا عبد المجيد، اللي بتتنقل داخل المستشفيات، يعني مثلا مريض ضغط او مريض يعمل عمليه زي ما انتوا قلتوا. مين قال هنا؟ عبد المجيد. عدوى جراحيه، ايوه، رايح يعمل عمليه معينه يجي له عدوى. طيب ايه تاني ممكن؟ UTI. yes VAB ventilator association pneumonia. Yeah. Yes. MERS. Hiya, thank you. Yes, excellent. Yeah. Given the major impact of healthcare-associated infection on morbidity and mortality. الإعياء والوفيات، عشان في حوالي وفيات كتير، وشرحتها الدكتورة نورة إن عشان كده عملوا المستشفى الخدمات البشرية الأمريكية، وأنشأت وزارة الصحة الأمريكية هو منظمة الصحة العالمية والCDC اللي احنا قلنا عليهم من شوية. and cost of care، والتكاليف العالية والباهظة اللي بتحصل بخصوص العدوى اللي بتتنقل بعد دخول المرضى للمستشفيات. There have been many efforts to prevent the healthcare associated infection by improving infection prevention and control. This include established the US Department of Health and Human Services، دي اللي احنا بنقول عليها وزارة الصحة والخدمات البشرية الأمريكية. National Healthcare Associated Infection Action Plan required report of hospital. And here, Joint Commission National Patient Safety Goal specific to health care associated infection. This all organization, they did to prevent and make evidence-based for infection prevention and control. What we mean and what is the infection, what is the safety culture? Safety culture has been defined as the product of individual and group beliefs. ثقافة السلامة أو ثقافة سلامة المرضى هو عبارة عن إن هو نتاج المعتقدات الفردية والجماعية كلها. بتكون عبارة عن معتقدات فردية مثلا health care worker أو للمنظمة كلها. culture ثقافة بتكون يا فردية يا إما جماعية، أو قيم، مواقف، كفاءات، أنماط سلوك، هي كلها دي بتحدد التزام المؤسسة بالجودة بسلامة المرضى. Safety culture has been defined as a product of individual and group beliefs, value, attitude, perception, competences, and pattern of behaviors that determine the organization commitment to quality and patient safety according to ARC. A culture safety encompasses 4 key principles. عندنا 4 مبادئ أساسية للculture of safety. أول حاجة إن إحنا لازم يكون عندنا إقرار بطبيعة المخاطر اللي إحنا بنتعرض ليها، المخاطر العالية اللي بتتعرض ليها المنظمة أو المؤسسة الصحية بتاعتنا عشان نقدر نحقق ونوصل لاستقرار أو أمان للمرضى بتوعنا. أول حاجة لازم نبقى عارفينها في patient safety, the patient is the first. The second one, blame free. For healthcare worker, we should know, and the best role in health organization is in the safety culture, blame free. بيئة خالية من اللوم، إن إحنا ما نلومش حد. healthcare organization not individual, it's a system. يعني أي خطأ بيحصل في المستشفى بتاعتنا أو المؤسسة الصحية بتاعتنا مش هيكون خطأ بشري، لازم نبقى عارفين إنه خطأ system. Even the healthcare worker, he did the mistake, but we should know why, not who. Okay. The important is blame-free environment. The first one, acknowledgement of high-risk nature of an organization activities and determination to achieve constantly safe operation. The second one, a blame-free environment where individual can report error or near miss without fear of reprimand or punishment. ثقافة إن البيئة تبقى خالية من اللوم هيخلي الهيلث كير وركر أو الميديكال ستاف إن هو يقدر يبلغ عن أي خطأ بيحصل، sentinel event, near miss, OVR, everything without fear from the leaders or the COO or fear from they will cut the salary for him or إنه يعني مش هيخاف، خلاص هيقدر يبلغ عن أي حاجة بتحصل من لو البيئة أو المؤسسة بتاعتنا بتطبق patient safety culture صح. blame free. في كل المحاضرات أنا لازم أقول blame free أهم حاجة، يعني عشان يقدر الهيلث كير وركر إن هو أو الميديكال ستاف إن هو يبلغ عن sentinel even near miss, because the near miss lead to be sentinel event. Okay. The third one, encouragement of collaboration across rank and discipline to seek solution to patient safety problem. إن إحنا نشجع from من أكبر حد في المؤسسة لحد أصغر حد، لازم يبقى فيه تشجيع وتطبيق لثقافة سلامة المرضى. The fourth, organizational commitment of resources to address safety concern. لازم يبقى في التزام من المنظمة بالموارد عشان نقدر نعالج مخاوف السلامة في organization or our healthcare organization. Why we need to measure safety culture? Healthcare quality oversight bodies and related group recommend organization address a safety culture. Organization accredited by the Joint Commission are accepted to ensure that leader maintain a culture of safety and regularly evaluate the culture using a valid and reliable tools. لما نقيس ثقافة سلامة المرضى لازم بنستخدم أدوات valid and reliable. وده برضو we will talk about these tools later on also. The National Quality Forum recommend measurement of culture in its safe practice for healthcare. Similarly, the LeapFrog group. مجموعة LeapFrog دي non-profit organization برضو بتعمل على قياس ثقافة سلامة المرضى. وبتعمل مسح دايم كمان للمستشفيات بالنسبة للجودة والسلامة نفسها الاثنين يعني. ARC also recommends yearly measurement of safety culture as one its 10 patient safety tips for hospital. ومنظمة ARC also بتقول إن إحنا لازم سنويا نعمل على إن إحنا نقيس ثقافة سلامة المرضى في المستشفى بتاعتنا أو المنظمة الصحية بتاعتنا. طب did you know how we can measure the safety culture in our organization? Hello. ازاي نقدر نقيس ثقافة سلامة المرضى في المستشفى بتاعتنا؟ ازاي هنعرف ان احنا المستشفى بتاعتنا مطبقة سلامة المرضى او عندنا الكالتشر بتاعت السيفتي في الهيلث كير اورجانيزيشن بتاعتنا؟ how we know? Yes, excellent عبد المجيد, excellent. يعني مثلا في الانفكشن كنترول احنا مثلا عايز اعرف دلوقتي ان احنا مطبقين ثقافة سلامة المرضى في المستشفى ولا لا. الانفكشن كنترول تيم, yes excellent عبد المجيد, excellent. نعمل جولات في المستشفى ونشوف عندنا سياسات ولا لا ومطبقينها. احنا ممكن نبقى عاملين السياسات ومكتوبة ورق وبس و لا مؤاخذة يعني جايبين شركة تعمل لنا السياسات عشان نخلص عشان سباهي وناخد الترخيص وخلاص. لا, we should implement the culture in our organization please. وكمان محاضر لجان سلامة المرضى. أيوة, الأجندات والحاجات دي كلها بتعرفنا إن إحنا مطبقين سلامة المرضى ولا لأ. ممكن نعمل KPIs إن إحنا مثلا infection control teams يعملوا KPIs في competency for hand hygiene ولا لأ. الحاجات دي كلها منها هنقدر نعرف المؤسسة دي مطبقة patient safety culture ولا لأ. In infection control we have also KPIs. We have quality improvement project, صح؟ ممكن نعمل مشاريع تحسين منها هنعرف برضو احنا مطبقين ثقافة السلامة ولا لأ. Okay. Here. We have here the Nubedian frame. From this frame, we will know also how we can measure or why safety culture should be measured and how the mechanism by which safety culture can influence the infection prevention control process and health associated infection have been described in several conceptual model. This I am telling about it, the Nubedian model, many of which derive from the Nubedian model of the structure lead to process and structure and process lead to our outcome. This our figure. The first one from the structure here, like what structure in our organization hospital, or ممكن حد يقول لي ايه الستراكشر اللي ممكن يبقى في المؤسسات الصحية؟ We have structure and process and outcome. Okay, what is the structure in our healthcare organization? The structure like environment or all our equipment or staffing here. That is the organizational factor. And patient and staff characterize. Yes, Abdul Majid, thank you. Team member, yes, staff. This is our structure. Patient and staff characterize severity of illness, staff knowledge and beliefs. This I told you before, this attitude or value of lead to safety culture or adherence to infection prevention process. The safety culture like domains of teamwork, leadership support, or communication. Adherence of infection prevention control process like hand hygiene, contact precaution, bundled intervention. Then from the structure and our process, we can get our outcome. Healthcare associated infection like bloodstream infection, surgical site infection, like Abdul Majid and Ali Zahran, they told before. Bloodstream infection, UTI, surgical site infection. This our Nubedian frame can define, or from this frame we can know the relation between safety culture and the infection control and quality also. This presents simplified conceptual model for the relationship between safety culture, infection prevention control process, and health associated infection rates. Derived from the previous work, essentially the input of individual characterized, like I told before, both patient and staff interact with organizational structure. From this structure lead to the process, and we will get our outcome finally. Okay. يعني هنقول هنا إن المدخلات بتاعتنا الاستراكشر، المدخلات زي ما قال عبد المجيد the team member أو الستاف أو الانفايرومنت أو الاكويبمنت، هتودينا للبروسيس أو طريقة العمليات اللي احنا بنعملها داخل المستشفى. فبالاستراكشر والبروسيس هناخد الاوتكم او النتيجة بتاعتنا. and this the Dunobedian frame. We have challenged to link safety culture, infection prevention and control activities and outcome. There are several reasons why establishing a casual relationship between safety culture and infection prevention control process and healthcare associated infection has been difficult in previous research. A challenge to measurement and analysis for each of this area are described here below. Safety culture studies that measure safety culture often use different instruments which vary in physiometric properties such as reliability, validity, and sensitivity to change. The second one, perception of safety culture are not necessarily related to actual practice. For example, a qualitative study by this العالم ده he talk about the speak up. العالم ده عمل لنا لما اتكلم عن تصورات ثقافة المرضى describe how situational complexity of interaction affect both of willings and ability of staff to speak up. Why we need to speak up to prevent an error. Analysis of safety culture data may be too simplistic. For example, research debate whether to aggregate level of agreement. We talk about the challenge to measurement and analysis. The first one, safety culture, then infection prevention and control practice. Measuring adherence to infection prevention control practice is not easy. Measuring adherence to evidence-based care bundle using checklist, while more comprehensive, can be time-consuming and variable in approach, timing, and number. Just a second. Healthcare associated infection. Measurement of healthcare associated infection thought more standardized than infection prevention control. is heavily depend on time frame and surveillance process. عشان نقيس العدوى زي ما قلنا المرتبطة بالرعاية الصحية، أكتر حاجة بتعتمد عليها بشكل كبير على الإطار الزمني والسيرفيلانس، العمليات المراقبة. Some healthcare associated infection are more reliable to collect than others. بتبقى في بعض الأمراض أو بعض العدوى المرتبطة بالرعاية الصحية بتكون reliable أو أكتر موثوقية ونقدر نجمعها أكتر من غيرها، وهنقول أمثلة على الحاجات دي كلها. طبعا بتختلف في وحدة القياس من مستوى مثلا وحدة العناية المركزة أو على على مستوى المستشفى كلها أو على الإطار الفردي كمان. The unit of measurement, ICU level, hospital-wide, single health associated infection or multiple also varies. العوامل دي كلها بتأثر في جمع البيانات أو a factor that directly influence to the development of healthcare associated infection often differ according to healthcare associated infection of interest and are greatly affected by patient risk characterized as comorbidities. في عوامل تانية برضو بتختلف وبتأثر بشكل مباشر على العدوى المرتبطة بالرعاية الصحية، بتتأثر بشكل كبير، وخاصة اللي بتكون فيها خصائص مخاطر للمريض زي الأمراض اللي بتكون مشتركة such as comorbidities. Establishment attribution for the healthcare associate is challenging as described by Gardam during the hospital stay. A patient can be exposed to thousands of different environment and human contact. They may be lead to infection. ممكن يتعرض المريض لآلاف من الكوميونيكيشن بين المرضى مثلا، بين الموظفين، بين patient to patient, patient to family, patient to healthcare worker, healthcare worker to healthcare worker. دي كلها ممكن برضو بتأثر وبتعمل زي تحديات إن احنا نقيس أو نحلل البيانات بتاعتنا في جمع المعلومات للعدوى المرتبطة بالرعاية الصحية. Direction and causation. Directionally for cause and effect regarding infection prevention control, improvement and safety culture remain to be established. For example, can improve infection prevention control process result enhanced safety culture, or does improvement in safety culture result in better infection prevention control process? Ability to establish a relationship and causality is of course affected by purpose of initiative as well as the study designed practically when there is a control group. Quality improvement research is synthetic in its focus on broader generalizable research question with multiple sites and advanced statistical analysis. This all about challenge linking safety culture and infection prevention and control activities and outcome. A demonstration project on the impact of safety culture on infection control practice in hemodialysis. This one we will talk about it tomorrow, not now. Now we will just a second. I will open the other slide. طيب لحد ما السلايد معلق بس لحد ما يفتح. We will talk. Just a second. Yes, it's open now. appear. الشاشة واضحة ولا؟ Hello. في بيقولوا لا أو يس. لا مش واضح. طيب just a second. كده واضح؟ no. Yes, okay. تمام. Infection control, infection prevention and control are practices and activities that the first prevent patient and healthcare worker from being harmed and avoidable infection. Ensuring good infection prevention control, avoid harm, time, even death, save money, reduce the spread and antimicrobial resistance, support the delivery of high quality health service. Okay, thank you, Reem Ali. Now we will know about the standard precaution. All patients at all time. Standard precaution are meant to reduce the risk of transmission of bloodborne and other pathogen from both recognized and unrecognized source. They are basis level of infection control precaution, which are to be used as a minimize in all patient care setting. Risk assessment is critical. Assess all healthcare activities to determine the personal protection and it's indicated. Here, the effective infection prevention and control required constant action at all levels of the health system. From policymaker to facility manager, healthcare worker, hygiene specialized, and those who access health service. Here that we told before. Now we have example about quality initiative academic medical center from 2009 until 2012. دي مبادرة لتحسين الجودة في 2000 هي اتعملت أصلا في 2013. عملوا قياس من 2009 ل 2012. طبعا كانوا بيتكلموا إنهم أو القياس عن تحسين التزام بنظافة الإيدين، زي ما قلنا إن إحنا إزاي هنقيس culture of safety with infection control. هيبقى فيه عندنا المفروض أمثلة كتير زي الالتزام بثقافة نظافة الإيدين، أو إن إحنا نعمل مثلا check list for all department the medical department إن هم عارفين ال5 whys ولا لأ. ممكن ايه تاني نقدر نقيس بيه في الهيلث كير وركر هيلث كير اورجانيزيشن؟ قلنا الهاند هايجين and checklist for like 5 whys. طيب نقول هنا المثال أو المشروع اللي اتعمل لتحسين الجودة: الالتزام بنظافة الإيدين to improve hand hygiene adherence and align effort with pursuit at the culture of safety. وإن هما لازم يكون في جهود عشان يسعوا لتحقيق ثقافة السلامة في المستشفى نفسها. المستشفى عملت إيه؟ عملت استراتيجيات كتيرة عشان يقدروا يطبقوا ثقافة السلامة بالنسبة لنظافة الإيدين. أول حاجة عملوها طبعا الليدرز، إنه أول حاجة لازم يبقى فيه leadership commitment. أي مشروع أو أي حاجة تبع الجودة أو patient safety even infection control it should be there is leadership commitment. أوكي. طب هم عملوا إيه؟ عملوا تدريب. Here the hospital adopted multiple strategies include training, peer feedback. يبقى في ردود لل peer الأقران أو وماركتينج and financial، عملوا تسويق وحوافز مالية عشان يشوفوا الناس ملتزمة ومطبقة نظافة الإيدين في المستشفى ولا لأ، hand hygiene or as well as structured unit-based and individual accountability intervention. ده غير زي ما قلنا input for the organization. What they found, not measured directly, also the response of underperforming units, improvement plan provided, leader with insight into the safety culture in each poorly performing clinical area. And desire to work as a team or alternatively disinfection, dysfunction, and lack of leadership. Our process is hand hygiene. Improvement in hand hygiene were sustained across the entire health system. The second, leadership engagement through a formal accountability structure coupled with institution financial incentive encourage both nursing and physician leadership to pursue a culture of constant, sustained healthcare adherence. Here, the last one, safety culture net measured also. The other example, quality improvement initiative intervention at single dialysis clinics with 5 control sites from 2017 until 2018. كانوا بيتكلموا هنا عن التدخل في عيادات غسيل الكلى. واحدة من 5 مواقع Comprehensive Unit Based Safety Program. كان الهدف هو تحسين فهم ثقافة السلامة في الوحدة وموائمة الممارسة العلاجية أو السريرية مع التدخلات الأساسية للCDC. عملوا مسح أو عمليات تدقيق شهرية عشان يشوفوا وقاية العدوى أو الوقاية من العدوى مطبقينها في غسيل الكلى ولا لأ، والإجراءات الحاسمة عشان يمنعوا من حدوث العدوى في غسيل الكلى أو التهابات مجرى الدم. Here, hospital survey of patient safety culture and modify for dialysis clinical domains with teamwork, communication. This all improvement project we will do now, but it will be about VAB, teamwork, communication, management, support, continuous improvement, organizational learning. Then that is the monthly infection prevention practice audit. Hemodialysis is bundle and procedure considered critical to prevent CLABSI. The bloodstream infection. Infection rate decreased from, when they make this project, infection rate decreased from 2.33 to 1.7 even per 100 patient months. في الشهر انخفضت معدلات الإصابة بعد ما عملوا المشاريع التحسين بالنسبة لتقليل العدوى في الغسيل الكلوي أو تقليل التهابات مجرى الدم. قلت المعدل من 2.33 من 2.3 ل 1.07. حدث لكل 100 مريض في الشهر، وده معدل هايل جدا إن هو بعد مشاريع التحسين تنزل بالمعدل ده. and standardized infection ratio، ومعدلات الإصابة كمان المعيارية اتغيرت من 1.96 to 99.99 in 12 months after. بعد 12 شهر قاسوا برضو لقوها من 1 في خلال 12 شهر بعد ما نفذوا المشروع بتاع التحسين ده، لقوا إنها نزلت من 1.96 ل 0.99، وده برضو معدل كبير وكويس جدا. After implementation baseline data from 6 sites indicated a strong negative relationship between staff perception of safety and bloodstream infection rate. Become 0.017. عشان كده لما يكون معدل انخفاض ثقافة سلامة المرضى بالنسبة إن في عدوى منتشرة مثلًا في الغسيل الكلوي، أو إن هم يعملوا الhand hygiene، إن هم يلبسوا الBPI صح، إن هم يطبّقوا الpatient safety culture صح في with infection control. لو قلّت الإدراك الموظفين بالثقافة دي، هتزيد عندنا الblood stream infection. تمام؟ من هنا يبقى ده هيأكد إن ثقافة سلامة المرضى بترتبط، أو there is relationship between of culture of safety with improvement of outcome for our patient. Here, the lower the staff perceive the safety culture, the higher of the bloodstream infection rated tend to be at the beginning of project. Enhanced patient safety culture is correlated with improved patient outcome. This project, it's in the dialysis clinic. And we will do the next lecture about also improvement project about VAP. Thank you. You have any questions? You have any questions? You have any question in this lecture about the culture of safety and impact on the improvement of infection control, infection prevention control? Thank you عبد المجيد. Thank you. أعتقد يا عبد المجيد أنت بس اللي مركز معايا يعني. في أي أسئلة؟ في المحاضرة دي؟ عندكم أي أسئلة قبل ما نروح بقى للمحاضرة التانية ونعمل مشاريع تحسين؟ Thank you ابتسام. هننفذ دلوقتي مشروع تحسين بالنسبة لمكافحة العدوى، ويا ريت تتفاعلوا معايا إن إحنا نعمل مشاريع تانية. يعني المشروع اللي أنا جايباه about the quality improvement initiative with infection control, I made about the VAB. We need more. Thank you Zainab. We need more quality improvement project, please, like hand hygiene, like Kauti. I need more project with me, please, عشان نتعلم ونفهم ازاي نعمل مشاريع تحسين في الانفكشن كنترول. هو طبعا يعني الافضل المشاريع التحسين بتبقى عامة، بس احنا دلوقتي بنتكلم عن infection control. We need more project improvement about infection prevention control. Okay, any questions? عندكم أي أسئلة قبل ما ننقل للمحاضرة التانية؟ Thank you هيا. Okay, أسأل أنا طيب؟ Thank you جوهرة هيا. Okay. What is the relationship between safety culture and infection prevention control? and why we have relation between both of them. Yeah, thank you. Positive relationship. Excellent. الصوت بيقطع. ليه في علاقة أو إيه هي العلاقة أو ليه العلاقة دي بين البيشنت سيفتي كلتشر و الانفكشن كنترول بريفنشن؟ إيه سبب العلاقة دي؟ If we maintain the safety culture, yes, excellent, Ali, excellent. Positive relationship, and when we maintain the safety culture, we can reduce the infection. And when we have the high safety culture in our organization, we prevent before it's happening. Like as we know, there is FEMIA. يعني من قبل ما يعني احنا هنقدر نمنع ان يحصل اي مشاكل او انفكشن او اي عدوى من قبل ما تحصل اصلا. احنا لو عندنا ثقافة السلامة مطبقة في المؤسسة الصحية بتاعتنا، يبقى هنقدر نمنع ان هو يحصل اي انفكشن من قبل ما يحصل. طب ازاي نقدر نمنع حدوث اي انفكشن عن طريق ثقافة سلامة المرضى؟ ازاي؟ يعني مثلا في الجراحة، ازاي نقدر نمنع ان هو يحصل اي انفكشن عندنا بعد ما الجراحة بتاعتنا تخلص؟ زي ايه مثلا؟ الدكتورة نورة شرحت حاجات كتير بالنسبة للحاجات دي. Yes, excellent هيا, excellent. Thank you. Hand hygiene. إن إحنا نعمل الدكاترة والستاف و all healthcare worker in the surgeon department, they should make the hand hygiene. They should implement the right hand hygiene rules. Okay? And hand off. Time. Cleaning, aseptic technique. This all, I think Dr. Noura, yeah. Dr. Noura, she talked about it all this aseptic technique. Okay. Type, we have two types of hand hygiene. We have two types of hand hygiene. Like what, please? Yes, excellent, Haya. And hand rub. Yes, excellent. Hand wash and hand rub. Thank you, Haya. Thank you. Excellent. طيب ننتقل للمحاضرة اللي بعد كده. خلاص ما فيش أي أسئلة أكيد. تمام. Thank you, Haya. quality improvement. Yeah. Now we will talk about a quality improvement initiative in infection control and how we can implement our quality improvement project in infection control. عشان نستخدم مشروع تحسين أو نعمل مشروع تحسين للجودة، في عندنا methods أو منهجية معينة methodology بنسميها focus BDCA. plan do check act. عملوا العالم ديمينج، هو طبعا اللي عملوا الأول شوهارت، بعد كده نفذوا العالم ديمينج. دول 2 علماء إحصاء في اليابان. هم طبعا نفذوها لمشاريع التحسين في المصانع. في الأول كنا بنستخدم طبعا أغلب الحاجات اللي بنستخدمها حاليا في الجودة كانت بتستخدم في التصنيع، وبعد كده بقت الهيلث كير وركر دلوقتي في الهيلث كير اورجانيزيشن. تمام. We will talk about ventilator associated pneumonia prevention quality improvement project. Our methodology it's focus BDCA. Who knows about focus BDCA or what we means about focus BDCA? Anybody knows about focus BDCA? Or what we means in ventilator associated pneumonia? عندي سؤالين، حد عارف يعني ايه ventilator associated pneumonia او حد عنده فكرة عن الفوكس BDCA before starting؟ صريحة قوي يا هيا. اوكي. تمام. ها في حد طب عارف يا هيا تعرفي ايه هي الفنتليتور associated pneumonia؟ Did you know about ventilator associated pneumonia? That's in infection control. It will be in ICU. طيب ماشي، مصدقاكي والله يا هيا. اوكي. طيب الفنتوليتور اسوشيات بنيمونيا ده نوع من انواع العدوى الرئه بتحدث للناس اللي بتستخدم اجهزه تنفسيه زي الجهاز اللي احنا شايفينه ده، جهاز تهويه ميكانيكيه بتبقى في المستشفيات. بتحصل منها بعض العدوى لالتهاب رئوي مصاحب للجهاز التنفسي الصناعي. ايوه ثانك يو قاسم excellent. التهاب رئوي مصاحب للجهاز التنفسي الصناعي. الجهاز اللي احنا شايفينه بيبقى في الاي سي يو، ممكن يحصل منه عدوى او التهاب رئوي للمرضى اللي بيكونوا مركبين أجهزة تنفس صناعية. طيب عايزين نعمل بقى إيه؟ نقلل من العدوى اللي بتحصل دي. Our methodology نموذج التحسين المستمر continuous quality improvement. That is our methodology about quality or continuous quality improvement. Focus BDCA. Find process improvement opportunity. Every alphabet means something. The first one, find process improvement opportunity. The second one, organize a team. The third one, clarify the current knowledge of the process. And you uncover the root cause of variation or poor outcomes. Then S, we will start, plan, do, check, act, just such as I talk before. It's from the deeming cycle, plan, do, check, act for continuous quality improvement. Here it's not appear well, but we will talk about all now. أول حاجة عايزين نعملها في مشروع التحسين، لازم ندور على المنطقة أو المكان اللي احنا عايزين نعمل فيه improvement, area for improvement. عايزين نحسن مثلا زي ما قلنا من الفاب، نقلل العدوى المصاحبة للجهاز التنفسي ده والالتهاب الرئوي المصاحب للجهاز التنفسي. يبقى لازم نحدد الهدف بتاعنا صح، لازم نحدد area of improvement صح. Find opportunity. The first one, F, find opportunity for improvement. Implement VAB bundle، إن إحنا ننفذ الباندل of VAB ونعمل تثقيف للموظفين ونقلل الريت للفنتوليتر associated pneumonia. This our F, find opportunity for improvement. فرصة التحسين بتاعتنا أو area of improvement. Now our aim in this project, implement VAB bundle, educate staff, decrease VAB rate. Now we will organize a team. احنا أول حاجة عرفنا الهدف بتاعنا، عايزين نقلل من العدوى، نعمل تثقيف للموظفين و bundle of VAB. تمام. طب عايزين نعمل تيم، مين من الموظفين او من الستاف بتاعنا هيبقى المفروض ان احنا يبقى معانا في التيم؟ عايزين نقلل عدوى في الاي سي يو مثلا، عايزين نقلل العدوى من الالتهاب الرئوي ده اللي بيحصل في الاي سي يو. عايزين نكون فريق، ممكن يبقى مين معانا في الفريق؟ احنا في مستشفى دلوقتي حصلت مشكلة وعايزين نقلل، بيحصل مثلا من 20 ل 30% من المرضى، أو هنقول مثلا أكتر، نقول 60% من المرضى بيحصل لهم العدوى دي في الاي سي يو. يبقى أول حاجة إن احنا نشوف فرص التحسين بتاعتنا، نقلل من المعدل ده اللي احنا قلنا عليه 60%، عايزين نقلله، وعايزين نثقف الموظفين الأول عشان نقدر نقلل من معدل العدوى اللي بيحصل عندنا. طب ناخد مين بقى من الأقسام عشان يبقى معانا في التيم عشان نعمل مشروع التحسين ده؟ Yes, excellent. قسم التعقيم لازم. اوكي excellent يا هيا. مين تاني؟ عايزين نعمل فريق. احنا دلوقتي مع بعض عايزين نعمل اجتماع. يا جدعان بيحصل مشكلة في القسم الاي سي يو، وعندنا معدل عدوى في الالتهاب الرئوي اللي بيحصل للمرضى من الجهاز ده بيحصل بمعدل 60%. عايزين نقلل. الكلينر شور يس. التعقيم. الهاوس كيبر. طبعا كل حد هيبقى منه موظف معين او الهيد بتاع القسم ده مثلا. ها مين برضو ممكن يبقى معانا في التيم؟ عايزين نعمل مشروع تحسين. اجتماع مع بعض في المستشفى، حصل عدوى في مكان معين، المفروض يبقى معانا مين؟ يس اكسلنت. اخصائي الوبائيات. تمام، يعني ده اللي هنقول عليه مثلا آه، مدير انفكشن كنترول مثلا، ولا اخصائي الوبائيات. طب ليه انت قلت اخصائي الوبائيات يا قاسم؟ ازيك يا قاسم؟ اعتقد انت بتبقى معايا على طول دايما في المحاضرات. I think يعني. يس اكسلنت، عشان هو تبع الانفكشن كنترول، وهو اللي هيفهمنا الايفيدنس بيز لاين اباوت فاب. اول محاضرة، اهلا وسهلا بيك. هو هيكون عنده برضو الايفيدنس بيز. تمام اوكي. مين تاني؟ اخصائي الوبائيات. الكلينر. قلنا تاني مين هنا؟ الموظف اللي موجود في قسم التعقيم، اي موظف طبعا، او الهيد اوف ديبارتمنت. اوكي مين تاني؟ اول حاجه مدير قسم مكافحه العدوى، هو اللي هيعمل الاجتماع بتاعنا. The infection control manager. رئيسة التمريض مثلا، او حد من التمريض. يعني هو مين اللي هيعمل تثقيف للموظفين او تثقيف للتمريض اللي موجود عندنا جوه القسم. يبقى عايزين برضو health educator. ها مين تاني؟ لازم يبقى معانا physician. الاي سي يو هيد نيرس. طب الحاجات دي كلها مكتوبة قدامكم، اغششكم اكتر من كده؟ يبقى عايزين نعمل الاورجنايز تيم. The first one infection control manager, then quality department manager, one specialized physician, ICU head nurse, respiratory team, education department, and two registered nurse with a master degree in adult acute care and nursing service administration, who have a very well capability for research and training. عشان يبقى عندهم طبعا اتنين التمريض دول، عشان يبقى عندهم قدرات عالية أو جيدة إن هم يقدروا يعملوا ريسيرش وتدريب. تمام. This our O from focus BDCA. قلنا أول حاجة الF find، نشوف area of improvement أو ندور على فرص التحسين بتاعتنا. find. O organize team. C clarify the current process. Here previous verb rate was increased. التانية هتبقى أوضح شوية. السلايد اللي بعده. Here the C of focus it clarify the current process. Our previous process VAB rate was increased. No staff read or follow VAB policy. الحاجات دي كلها احنا لازم هنعملها على fishbone. No staff implement VAB bundle. مفيش staff بينفذ الVAB bundle، أو مفيش staff أصلا بيقرأ البوليسي بتاعت الVAB اللي عاملينها في المستشفى، سياسات ولا بيتبعوها ولا بيقروها ولا عارفين عنها حاجة. Closed section system was not available. Staff unaware of VAB rate for hospital. ما عندهمش وعي أصلا بالمعدل العدوى أو انتشار العدوى اللي بتحصل في مستشفى. Here, understand you from our focus. You understand process variation. هنا في الفيش بون أو cause and effect diagram أو إيشيكاوا diagram، دي كل المسميات بتاعتها. لما نعمل الفيش بون، أول حاجة عند المربع ده عند رأس السمكة، هو ده اللي بنكتب فيه المشكلة بتاعتنا الأساسية. احنا قلنا VAB ventilating associate pneumonia rates in ICU. عايزين نقلل معدل الالتهاب الرئوي اللي بيحصل في ICU. طب ازاي؟ هنحدد عن طريق البوليسي أو المان باور، الماشينز، places. Policy, like we told, no compliance with policy. The manpower, no education of staff. Physician not following through with VAB bundle. Staff unaware of element of VAB. VAB rate monitored by infection control. Here places intensive care unit. البلاس بتاعنا هيكون ICU. الدايجرام ده اسمه cause and effect، السبب وتأثيرها. الأسباب مثلا اللي أدت إن إحنا معدل الفاب بتاعنا يبقى عالي في ICU، وده طلعنا الأسباب دي إزاي؟ عن طريق brainstorming، عملنا عصف ذهني مع التيم اللي إحنا كوناه. مش إحنا كوننا تيم في الأورجنايز تيم، مش كوننا تيم فريق كده، هنقعد مع بعض ونعمل حاجة اسمها عصف ذهني brainstorming، إن هم كل واحد يطلع الأفكار بتاعته. يعني هي زي ما قالت even the cleaner، إحنا ما نعرفش هو من ناحيته إيه الأفكار اللي ممكن يقولها لنا هتفيدنا في المشروع بتاعنا، صح؟ فالأسباب دي كلها اللي موجودة هنا في الفيش بون إحنا طلعناها من أفكار التيم اللي عملناه. تمام؟ يبقى هنا understand يعني معناها أنا عايز أفهم. understand process variation عايز أفهم، بس هفهم إزاي؟ هفهم عن طريق البرين ستورمينج أو العصف الذهني اللي هنعمله إحنا والتيم بتاعنا عشان ندور على أسباب المشكلة دي كلها. why we have the high rate of VAB. Okay, and how we will understand by the fishbone or 5 whys or root cause analysis or thing like prioritization matrix. شكرا شكرا يا هيا، تسلم يا رب. Thank you. We have how many tools for understand our variation in our project or quality improvement project. زي ما قلنا عندنا أدوات كتير نقدر نعرف بيها مثلا أسباب الأفكار، نقدر نشوف أولوية الأسباب كمان. في حاجة اسمها prioritization matrix، الأولوية، مصفوفة الأولوية. في عندنا الفلو تشارت، دي كلها بنستخدمها في الكلاريفاي. مالتي فوتنج، عندنا البرين ستورمينج and affinity diagram. برضو ده عبارة عن أفكار كده أو مصفوفة بتتحط، بيبقى مثلا بالألوان، بيقولوا الأفكار بتاعتهم تبقى بالألوان. أو عصف ذهني زي ما قلنا. This all tools we can use in clarify and understand our process variation. تمام. ممكن نستخدم حاجة اسمها زي ما هنا مكتوب ال 5B 5M and 6B، هنتكلم عنه برضو بعدين. ده كله في الفيش بون. يبقى أول حاجة البوليسي، نشوف السياسة بتاعتنا. المان باور، الأشخاص، الأفراد أو الأشخاص، البيبل، المان باور أو الميجرمنت، القياس مثلا، البليس، الأماكن أو المكان، الماشينز، الأجهزة اللي هنستخدمها. This our U from focus PDCA. Now we will talk about the S. هنعمل select the best practice. طب what we have in our best practice for VAB in ICU? Evaluation of the head of the bed to prevent aspiration and pooling of secretion. نرفع راس السرير عشان نمنع pooling of secretion، تجمع الإفرازات مثلا. Daily sedation vacations and assessment of readiness to extube early. التخدير اليومي، ونقيم جاهزية إن احنا نشيل التيوبس بدري على طول يعني. Peptic ulcer disease prophylaxis important for preventing of GI bleeding. ان احنا يبقى عندنا وقاية من مرض القرحة الجي اي او القرحة البروفيلاكسيس قرحة المعدة، عشان يبقى فيه وقاية من نزيف الجهاز الهضمي. ونعمل وقاية برضو من الDVT او التخثر الوريدي. Daily oral care with chlorohydroxyline. ده select our the best practice. From here we will select our quality improvement methodology BDCA. Okay. After S we will here ventilator associated pneumonia is reported to be most common hospital acquired infection among patients require mechanical ventilation. The estimation for the cost of care for a patient with VAB is شايفين التكلفة عالية جدا، $40,000 ل $57,000 higher per occurrence than the cost of care of a patient treated with mechanical ventilation in whom VAB doesn't develop. التارجت بتاعنا 100% all ventilated patient. اليونت اللي هنستخدمه زي ما قلنا ICU. احنا دلوقتي بنحدد كل حاجة قبل ما ندخل في BDCA. تمام؟ احنا عملنا فوكس دلوقتي، عملنا فوكس وخلصناه. find our opportunity for improvement, organize team, clarify, understand our process and select the best practice. تمام؟ في البلان بقى أنا عشان أحدد الخطة بتاعتي اللي هنفذ بيها كل الحاجات اللي قلنا عليها دي، عندي 5 عوامل لازم تبقى موجودة في البلان. المكان اللي هعمل فيه الامبروفمنت، لازم الهدف بتاعي يبقى ذكي. يعني ايه الهدف بتاعي يبقى ذكي؟ we should have a smart of goals. الهدف بتاعي لازم يكون بيأثر في المكان اللي انا هعمل فيه المشروع. يعني يمكن يكون مثلا اكتر خطوره high risk high volume patient prone problem prone and high cost. هيأثر في الفلوس زي ما قلنا شفنا شايفين دلوقتي اللي بيأثر من 40,000 ل 57,000 التكلفة بتاعته. تكلفة المريض الواحد هيكلف من 40,000 ل 57,000 لما يكون في التهاب رئوي مصاحب اللي قلنا عليه الفاب، يعني رقم خطير يعني. فهو هاي كوست هاي فوليوم وفي خطورة عالية، طبعا الفاب ممكن يؤدي للوفاة. طب high risk high volume and problem prone. ممكن يبقى يعني لو احنا سيبنا الموضوع ممكن ينتشر ويزيد ولا مش هينتشر ويزيد؟ خلاص كده هيفضل مثلا مريض واحد اللي حصل له التهاب يبقى خلاص؟ لا، طالما احنا ما عملناش تحسين بالنسبة للمشاكل اللي بتحصل يبقى الموضوع هيزيد. كان 10 مرضى ممكن بعد شهر نلاقيهم 60 مريض. فبروبلم برون يعني الموضوع قائم يعني. والهدف يبقى ذكي سمارت زي ما قلنا، ويبقى فيه تايم فريم. شايفين هنا التايم مكتوب من ديسمبر 2018 لنوفمبر 2019. الفترة دي اللي هنقيم فيه مثلا، احنا هنقولها حاليا يعني from 2023 to from January 2023 to December 2023 مثلا. The purpose of this project, we talked before about it, reduce the incident of VAP. How? Via improving the quality of care. Okay. Here we will do our plan. How we will do our plan of improvement, review and update VAP policy. ده الاكشن بلان بتاعنا اللي احنا هنعمله في المشروع، ان احنا نعمل تحديث ونراجع البوليسي بتاع الفاب. احنا طبعا في الاورجنايزيشن تيم جبنا هيلث educator. طب احنا جايبين هيلث educator ليه؟ develop training program for prevent VAP، عشان يتعمل لنا برضو تطوير برنامج تدريبي للوقاية من الفاب. الهيلث educator او health education هيساعدنا في الموضوع ده. create a ventilator bundle checklist، نعمل تشيك ليست للفاب باندل. monitor the policy compliance، عايزين بقى نشوف الناس بتنفذ أو بتنفذ السياسة بتاعتنا وبتقراها وبتتابعها وفي compliance ولا لأ. يبقى هنعمل monitor، هنراقب البوليسي compliance. and develop competency checklist for staff، برضو هنعمل تشيك ليست للستاف. This our action plan for improvement. Okay. مركزين معايا عشان هسألكم ونحاول نعمل أي مشروع مع بعض تاني. طبعا هيبقى أسهل حاجة إن احنا نعملها مع بعض hand hygiene competency project. تمام. مركزين شوية ماشي هيا. لا ركزوا كويس عشان نعمل بروجكت مع بعض. هاند هيوجين ان احنا نظافة الإيدين، نعمل مشروع صغير كده مع بعض عشان نفهم إحنا لما إحنا اللي نعمل المشروع هتفهموا أكتر من إن أنا مثلا حاجة مكتوبة وأشرحها لكم كده وخلاص. فإحنا مع بعض بليز، عايزة تفاعل إن إحنا نعمل مشروع تحسين hand hygiene competency practice. أوكي، يلا we will continue. Plan for improvement, review and update the policy. طبعا احنا قلنا الحاجات دي الأكشن بلان. The second one do. وهنا do يعني إن أنا implement in small scales. plan الخطة نفسها، تمام. do إن أنا أنفذ الخطة اللي أنا عملتها. احنا دلوقتي عملنا خطة أو أكشن بلان دلوقتي من شوية، إن احنا نعمل competency، إن احنا نعمل check list for staff، نعمل check list for الليستة اللي قبلها دي، نعمل ريفيو للبوليسي، نعمل training، develop training program، الحاجات دي كلها هنعملها، تمام، وننفذها على small scale، ننفذها في جزء معين. يعني مثلا قسم الاي سي يو بتاعنا كبير جدا، فهنفذه في حوالي مثلا 2 بيد مع السريرين دول، مثلا هم حوالي 100 سرير، ننفذه مع 2 بيد، او نقول خمس سراير مثلا. بس هننفذه ازاي في ال5 سراير دول؟ طبعا في تمريض، في دكتور، في سياسة مكتوبة، في حاجات كتير، فهننفذها في الجزء ده. ازاي ان احنا نطبق الحاجات اللي احنا عملناها او الخطة اللي احنا عملناها مع الجزء ده، الجزء المعين ده in small skills. وهشرح لكم حاجة كده تبقى ممكن تبقى مفهومة اكتر. هو اصلا لما عملوا البلان دو تشيك زي ما قلنا، اتعملت في التصنيع او المصانع، واللي عملها العالم ديمينج. فلما عملوها على طيران او طياره اسمها ايرباص 380، ممكن تبقى تدوروا عليها في جوجل. كان بيحصل مشكله في العجلات بتاعه الايرباص دي طبعا، ودي مشكله كبيره ان هو يحصل اي مشكله ان the airplane، هيبقى فيه وفيات كتير، خطر جامد يعني. ف نفذوه على small scales و they do the method of do in small scales. How they do that. عملوا اختبار بالنسبة لصعود وهبوط الطيارة نفسها بالنسبة للعجلات، وشافوا مثلا فيها مشاكل كتير بتحصل في العجلات دي، وما بتعمل صوت، مش بتنزل صح. فمين اللي هينفذها الأول؟ مهندسين و التكنيشن مثلا بتاع التكنيشن والمهندسين اللي هيظبطوا الطيارة، هم اللي صعدوا وهبطوا بالطيارة. يعني ما نفذوش الخطة أو الحاجة اللي هم أو التحسين اللي هم كانوا عايزين يعملوه بالنسبة للعجلات بتاعة الإيرباص دي، ما نفذوهاش وخلاص عملوا امبلمنت على طول وجابوا الركاب وطلعوا بيها. لا، هم طلعوا حوالي 20 دقيقة من في السماء من الأرض عشان يشوفوا الطيارة ماشية صح، بتصعد وتهبط صح ولا لأ. تمام. بعد كده، بعد ما عرفوا ان الحاجات او الخطة كلها اللي هم نفذوها زي ما احنا هنقول هنا in about the bab، هم راجعوا البوليسي ولقينا الستاف بينفذ البوليسي، لقيناهم عندهم التريننج بتاعهم كويس وبقوا فاهمين كويس صح how to make their hand hygiene، how to make the aseptic technique about the and 5 whys before and after patients، how to clean the environment. then هنقيس بعد كده، هنقيس بعد ما عملنا البلان بتاعنا ونفذناه على small scale زي ما قلنا 5 سراير مثلا من 100 سرير، هنشيك هل اللي احنا عملناه صح؟ هل اللي احنا عملناه هنحس منه فيه تحسين ولا لا؟ لو ما حسناش ان فيه تحسين بالنسبة للخطة اللي احنا عملناها او الإجراءات اللي عملناها، يبقى كده هنرجع تاني للخطة. يمكن في خلل في الخطة اللي احنا عملناه، يمكن في حاجة ناقصة في الخطة نفسها، يمكن في حاجة في الخطة نفسها أنا ما نفذتهاش صح. أنا عملت كريت فنتوليتور باندل تشيك ليست بس ما نفذتوش، يعني ما عملتش التشيك ليست، ما بروحش كل يوم أعمل تشيك، عاملة ليست عندي ومعلقاها في الحيطة وخلاص يعني، بس ما بروحش أشيك وأعمل تشيك every day، مفيش continuous. يبقى أنا لما in the second one do the improvement plan and practice are in place with continuous education and infection control and quality for implementation of the plan for both current and new staff. يبقى هنا ايه التحسين اللي انا هنفذه في السمول سكيلز؟ هعمل خطة والتعليم او التدريب بتاعنا المستمر هننفذه مع الموظفين اللي موجودين والجدد. اوكي، check. Here we will check our result. وهنا احنا لما نعمل التشيك بنعمل زي فلو تشارت برضو، بنشيك if yes يبقى خلاص احنا كده هننفذ الخطة بتاعتنا او التحسين اللي عملناه ده على نطاق اوسع. if no يبقى كده احنا هنعمل تاني، هنرجع للبلان تاني زي ما قلنا من شوية. يبقى comparison of data before and after implementation، هنعمل مقارنة للبيانات. احنا قلنا مثلا 60% من المرضى بيحصل لهم التهاب رئوي او معدل الالتهاب الرئوي بيزيد بحوالي 60% شهريا مثلا. هشوف البيانات بتاعتي بقى قبل ما انفذ الخطة بتاعتي دي وبعد ما نفذتها، واحدد النتائج اللي انا عايزاها. لو اتحققت يبقى هكمل وانفذه بقى على المستشفى كلها مثلا. لو ما اتحققتش هرجع تاني واشوف الديفكت بتاعي لو في عندي مشكلة في البلان ولا لا. Here the act. Keep monitoring and evaluation the process to ensure if the goal were met or not. هستمر بقى في ال evaluation بتاعي واشوف لو حققت الاهداف بتاعتي ولا لا. Sustain by implementing and ensure policy for VAB bundle for all patients in ICU on ventilator. هنفذ سياسة الفاب لجميع المرضى في وحدة العناية المركزة. Include VAB as a regular unit meeting agenda item. هحط الفاب ده بند من بنود جدول الأعمال بتاعتي في اجتماعات الوحدة. regular unit meeting agenda item. Ensure that all staff can verbally explain to you about VAB bundle. أبقى متأكدة إن كل الستاف بتاعي، طبعا احنا عملنا لهم training، ابقى متأكدة ان كل الستاف بتاعي هيقدر يشرح لي عن الفاب bundle. بعد كده communicate verb rate to the staff. هعرف الستاف بتاعي معدل الفاب اللي احنا لقيناه، يعني مثلا من 60% لقيناه بقى 40%. يبقى بعد ما لو لقينا احنا اتبعنا الإجراءات والخطة وكل حاجة بتاعتنا ولقيناها نزلت، يبقى هنعمل الحاجات دي، ان احنا communicate verb rate to staff. لازم يبقى كله عارف ان في تحسين حصل عندنا في القسم، ومن معدل 60 ل 40%. طب ليه احنا عايزين نعمل او نعرف الستاف بتاعنا او يبقى في communication؟ عشان المشروع بتاعنا ده خلاص مش هيقف كده، هو بقى 40% وخلاص اتحسن يبقى خلاص، لا، احنا لازم نعمل sustain، هيبقى او continuous improvement. المشروع بتاعي هيبقى مستمر. انا مش هعمله مثلا زي ما قلنا من يناير 2023 لغاية ديسمبر 2023 وهقف، لا، انا هقعد اكمل في المشروع ده لغاية ما الاقيه زيرو. او الجايد لاين مثلا، في رقم معين في الجايد لاين لغايه ما اوصل للرقم المعين للجايد لاين بتاعي. او انا مثلا هنا احنا قايلين ان احنا عايزين نبقى 100% من المرضى ما بيحصل لهمش انفكشن، زيرو هارم. تمام. ثانك يو ثانك يو ثانك يو. احنا عملنا كده المشروع بتاعنا، فعايزاكوا انتوا فهمتوا الاول البي دي سي اي والفوكس بي دي سي اي؟ فهمتوا معايا الفوكس بي دي سي اي؟ ثانك يو طارق. ثانك يو هيا. طب عايزين نعمل مشروع مع بعض about hand hygiene compliance مثلا، يعني ان احنا نزود من الستاف انهم يعملوا hand hygiene. مين معايا مركز عشان نقدر نعمل مشروع تاني مع بعض؟ Anybody can make the quality improvement project with me now. هيا طارق. Yes, excellent هيا, excellent. You can do it. Okay. The first, here we will find opportunity for improvement where we want to make the hand hygiene which unit, which department, which hospital، زي ما انتوا عايزين. شوفوا عايزين تعملوا ايه. yes مثلا في هي اصلا تبع مكافحة العدوى. انا عايزه اعمل مثلا الهاند هايجين في قسم معين، في قسم مثلا غسيل الكلى، hand hygiene in dialysis unit or مثلا in ER. اوكي. معايا هيا؟ عايزين نعمل مثلا مشروع تحسين للهاند هايجين، ان الستاف يعملوا الامتثال بالهاند هايجين، ان هم امتثال نظافة اليدين في الاي ار مثلا قسم الطوارئ. ده كده احنا عملنا ايه؟ find opportunity for improvement، فرص التحسين بتاعتنا. طب عايزين نعمل كده ليه؟ to educate staff وإن إحنا نقلل برضو من الانفكشن اللي بيحصل في قسم الطوارئ. Okay, this defined. Organize a team. طب عايزين نشوف بقى إيه مع بعض تيم. دلوقتي إحنا قلنا إحنا في الER. يبقى إيه التيم اللي إحنا هنكونه مع بعض؟ عايزين تيم عشان نعمل مشروع تحسين الامتثال لنظافة الأيدي or hand hygiene competence. Yes, excellent. رئيس مكافحة العدوى ورئيس الطوارئ. Yes, excellent, excellent يا هيا. Head of the infection control, head of the quality department manager or manager or head. أيوة الممرضين اللي في الطوارئ هناخد منهم تمريض مثلا 2 nurse from the ER, the head of ER head nurse also, وحد من education department. مين تاني؟ Okay, we organize our team already. طيب عايزين نوضح البروسيس بتاعنا مثلا. احنا ليه عايزين نعمل الهاند هايجين؟ هنقول برضو هنا زي ما قلنا في الفاب. yeah, yes, excellent. to نقول عليها ايه؟ minimize the infection in ER. Here we will put هنقول مثلا hand hygiene rate was increased. لا infection rate was increased. No staff read or follow the hand hygiene policy. No staff implement hand hygiene policy برضو. الstaff not aware about hand hygiene infection rate in ER. Okay. اللي احنا قلناه كله ده الكلاريفاي هنعمله على الفيش بون بتاعنا. البوليسي هنقول زي ما قلنا no compliance with policy. الستاف not هنا في المان باور staff not aware about the infection and hand hygiene rate. And there is no education of staff. طيب البليس ايه هو؟ هنقولنا احنا في ER. الماشينز ممكن ايه what we can make machines in the hand hygiene. هنقول مثلا عدم توافر المحلول، عدم توافر أماكن غسيل أيدي، ما عندناش أحواض إن الstaff يروحوا يغسلوا ويعملوا فيه الhand hygiene أو الhand wash بتاعهم، ما عندناش كحول عشان يعملوا الhand rub. تمام؟ أوكي. We will select the best practice. هنعمل checklist for compliance. ممكن نعمل إيه تاني؟ education. every week يروح قسم مثلا، يروح يروح حد من مكافحة العدوى يعمل education مثلا للتمريض والستاف الموجودين في الاي ار. نوفر المحاليل او الكحول في الاقسام، في كل مكتب مثلا او في كل section in the ER. نزود السينك، نعمل احواض على الاقل مثلا حوضين في القسم مثلا، يعني لو قسم كبير جدا او لو قسم صغير، او جنب كل سرير يبقى، او كل سريرين 3 يبقى فيه سينك معين للتمريض ان هي تقدر تستخدم او تعمل هاند واش بتاعها. ايه تاني؟ نعمل تشيك ليست ونشوف حد من مكافحة العدوى يروح يشوف تشيك ليست they make clean before and after patient ولا لا. الفايف وايز بينفذوا الفايف وايز ولا لا. المراقبة yes surveillance excellent يا هيا. المراقبة هتكون عن طريق ايه؟ ان هو حد يروح من الإدارة او من مكافحة العدوى يشوف هم بينفذوا فعلا الحاجات دي ولا لا. تشيك ليست. ممكن ايه تاني؟ ممكن نعمل لهم اختبار مثلا كل شيفت حد كده معين او رئيس الشيفت مثلا يروح يعمل لهم اختبار هم فعلا بينفذوا او هم فعلا عارفين ازاي يعملوا هاند واش وهاند راب، والوقت بتاع الهاند واش والهاند راب والمثلا الاتيكيت بتاع الكاف، الحاجات دي كلها. تمام. this select our best practice عشان نقلل من الانفكشن ريت في قسم الاي ار. طيب التارجت بتاعنا عايزين ايه؟ عايزين 0% من الانفكشن برضو في قسم الاي ار، والتايم نقول مثلا 3 شهور. البلان بتاعنا برضو same review and update the infection the hand hygiene policy, develop training program، نعمل برنامج تدريب. احنا قلنا طبعا create checklist، نعمل checklist للفايف وايز والهاند هايجين، الهاند واش، الهاند رب، كل واحد لوحده نعمل checklist ونعمل لهم اختبار مثلا. monitor the policy compliance، develop competency ايوه نفس التشيك ليست for staff. هنشيك بقى هل الحاجات اللي احنا عملناها دي we develop how many checklists and we make training for the staff. We will check now the staff become more improved or not yet. يعني مثلا هنفذه واشوف in ER we have 3 rooms مثلا، هنفذه على the first room. We'll see the stuff they become improve or not. They are not improve. يبقى كده هرجع للخطة بتاعتي تاني واشوف ليه why the stuff is they didn't improve the hand hygiene. If yes, خلاص we will implement in all the ER. This our act. Act to halt. يبقى هنعمل keep monitoring and evaluate the process to ensure if goal were met or not. If yes, we will implement in the big scale. If no, we will return again in our plan. And our BDCA, it should be cycle. لازم يبقى BDCA بتاع الخطة إن أنا أنفذ الخطة وإن أنا أشيك وإن أنا أنفذه على big scale. لازم يبقى دائري ولا ينفصل. plan do check act على طول. sustain continuous. عشان كده اسمه continuous quality improvement methodology. تمام؟ understand؟ فهمتوا؟ عندكم أي أسئلة؟ Did you have any questions? Thank you, Haya. You have any questions ولا ندخل في المحاضرة اللي بعدها على طول؟ Hello. معايا مركزين ولا روحتوا؟ You have any questions, please? You have any question about the quality improvement initiative? Amwaj, thank you, Amwaj. Rami, thank you for all. Thank you. خلاص. We will continue. طيب أسأل أنا. الفوكس معناه ايه؟ ممكن حد يقول لي كل حرف بيدل على ايه، او يقول لي كلمة مثلا الاف ايه هي، الاو، السي، يو، اس. find excellent هي find more yeah. thank you organized team. thank you هيا excellent والله. focus BDCA find organized team. clarify more answer please. طيب اجيبه لكم تاني، اجيب لكم السلايدات تاني. organized team. C means clarify the current process. U understand. S select the best practice. B plan. Do. D means do or implement in small scales. C check the result. A act in big scales. Okay, understand? Thank you, Haya. Thank you to all attendants. Now we will see the third lecture. Just a second until I will share the slides. ممكن ناخد بريك 10 دقايق لغاية ما أجيب السلايدات بتاعتي التانية، أو 5 دقايق بس ممكن. Hello, assalamu alaikum. The last lecture today, inshallah, we will talk about patient safety principle and methods applied to infection prevention control for suffer patient outcome. Why we have patient safety problem in healthcare? احنا ليه عندنا مشاكل في الهيلث كير بتخص سلامة المرضى أو سلامة المريض؟ ممكن يكون عشان الستاف ما عندهمش وعي، ممكن يكون عشان الستاف بيتغافل إن هو ينفذ الإجراءات الصحيحة. ممكن إيه تاني؟ Yes, excellent. Yeah. Non-implementing policy and procedure. We talked about it before. Here we will tell there is commission and omission. We have two things in patient safety culture, like names commission and omission. We will see the difference between commission and omission. Commission, doing something wrong that lead to infection. بيعملوا حاجة غلط هتؤدي للإصابة بالعدوى. هم already خلاص عملوا سياسات، عملوا إنهم عملوا الهاند هايجين ده في الكوميشن، بس ما لبسوش البي بي اي صح، ما عملوش مثلا التايم فور هاند راب exactly. doing something wrong. طيب عملوا حاجة معينة أدت للغلط ده. omission ده هيكون بدون قصد. الكوميشن هم عملوا حاجة غلط، هم يعني كبر دماغه وعملها، بس ايه بدل ما يعمل 30 من 20 ل 30 دقيقة عملها من 20 ل 30 ثانية عملها 10 ثواني بس، عايز يخلص وخلاص، يعني أنا مش لسه هاخد وقت، فكده اسمها كوميشن. هو عارف الصح فين بس he do something wrong but he know. طيب omission failure to do something right. هو عايز يعمل ده بس هو ما عندوش مثلا training. he want to do the proper hand hygiene or hand rub or hand wash but he don't know the how many seconds. يبقى commission هو عارف بس عايز يخلص بسرعة، عايز يعني هو يعني مثلا ايه هنقول ان هو عمل اجراء معين، الاجراءات كلها ما طبقهاش كلها، عندي 5 اجراءات طبق 4 بس هو عارف ان في 5 اجراءات. لكن omission هو عارف ان في 5 اجراءات وطبق ال5 اجراءات بس ما طبقهمش صح، لان هو ما عندوش مثلا training، ما عندوش وعي، staff جديد، عنده lack of staff هو لوحده مثلا، فما عرفش يطبق ال5 اجراءات صح. تمام. That is the difference between commission and omission. Doing something wrong that lead to infection, such as using the wrong antiseptic to prepare skin, keeping the urinary catheter bag above the patient's bladder, or selecting the wrong solution from a shelf to irrigate a wound. Okay? Omission, failure to do something right, not performing hand hygiene after removing gloves, not examine a catheter insertion site regularly, not using an aseptic technique when inspecting a dressing over a central line insertion site. Errors such as this may be prevented by leadership providing resources. طب الأخطاء اللي حصلت دي إزاي هنعمل لها prevent؟ عن طريق إن إحنا نوفر الريسورسز للستاف بتاعنا عن طريق الليدرشيب. عشان كده leadership commitment is too important in patient safety and quality. Even the infection control in the organization, in the healthcare organization, it's too important leadership commitment in everywhere. Even walk around for the staff, to encourage staff, the leadership is important also. Such as education for the staff and hand washing facility or hand hygiene supplies. نوفر التدريب للموظفين، مرافق الغسيل زي السينك والالكحول والحاجات اللي بتستخدمها لنظافة اليدين. By care provide who use this resource effectively. Infection formerly thought to be inevitable, such as when the VAB, we talk about it before, central line associated bloodstream infection, and catheter, the CAUTI, CLABSI and CAUTI. And can very often be prevented when evidence-based safety practices are applied constantly. The patient safety principle and method apply to infection prevention, control, and risk reduction for suffer patient outcome. A culture of patient safety involves, here like we told before, the leadership, teamwork, and collaboration, evidence-based practice, effective communication, and learning measurement, just culture, system thinking, human factor, and zero tolerance. يبقى احنا هتتضمن ثقافة سلامة المرضى. أول حاجة هنتكلم عنها الليدرشيب، القيادة، teamwork and collaboration، العمل الجماعي والتعاون، الممارسات القائمة على الأدلة، evidence based practice، effective communication، التواصل الفعال، والسلوك البشري، learning factor، والmeasure، والjust culture، الثقافة العادلة، health organization، zero tolerance. كل موضوع من الحاجات دي كلها في الانفكشن كنترول هتعمل هتقلل لنا من مخاطر العدوى. هنتكلم عن كل حاجة بالنسبة ل infection prevention control strategy، عن استخدام الحاجات دي أو طريقة أو استراتيجية الحاجات دي مع infection control prevention. Such we told before: leadership, teamwork and cooperation, evidence-based practice, organizational learning, and we will talk with each topic. Measuring care, process and outcome, system thinking, and human behavior, human factor theory, no blame, just culture, zero tolerance philosophy, high reliability, effective and open communication. The leadership. Leadership strategy for infection prevention professional. استراتيجية leadership في infection prevention control. Engage leaders formally and informally throughout the organization in support of infection prevention control. Assist them to increase the visibility and importance of infection prevention. لما الإدارة بتاعتنا أو القيادة بتاعتنا نشوفها بتنفذ الحاجات أو الاستراتيجيات الخاصة بالإنفكشن كنترول أو بيأكدوا عليها بطريقة مباشرة أو غير مباشرة، عن طريق مثلا إنهم بيساعدوا في إنهم يوفروا لنا الريسورس، بيساعدوا في إنهم يوفروا للستاف education، يعملوا لهم دورات تدريبية. الحاجات المباشرة أو الغير مباشرة. مباشرة كمان إن مثلا walk around، إنهم يلفوا أو يشوفوا الأقسام ويشوفوا الستاف بينفذوا they implement the hand hygiene، they implement the 5Y، هم بينفذوا الحاجات اللي احنا بنقول عليها ولا لا. الليدرشيب بطريقة مباشرة أو غير مباشرة. طيب هم لو القيادة عملت كده إيه اللي هيحصل؟ هنلاقي الاستاف كله أو المنظمة كلها بتتبع الليدرشيب. لكن أنا مثلا القيادة بتاعتي مش بتوفر لي الريسورس، أنا كاستاف ليه هعمل هاند هايجين؟ ما عنديش ريسورس اوريدي، خلاص ما فيش اهتمام من الإدارة نفسها، ما فيش اهتمام من القيادة نفسها. Why I should do my hand hygiene? No need. It's not important for leaders like that. It's not. They will not be important also for the other staff or healthcare worker. يبقى لما القيادة بتاعتي هتشاركني في الاستراتيجية الانفكشن كنترول بريفنشن، هتعمل لي زيادة في الوضوح وأهمية الانفكشن، أهمية الوقاية من العدوى. Seek visible true commitment from the senior executive and the board of government, clinical and support department leader, and key staff to infection prevention principle and practice. We talk about it already. Present a compelling case to leader that emphasizes the decreased morbidity and mortality and cost when infection are avoided. لازم أنا كأخصائي جودة مثلا أو أخصائي مكافحة عدوى أبقى مفهمة القيادة أو الإدارة بتاعتي إن أنا لما حضرتك مثلا تنفذ أو تساعدني في إن إحنا ننفذ أو نمنع أو نقلل من العدوى اللي بتحصل في المستشفى، إن الحاجات دي هتوفر لي كوست عالي. لما أقلل مثلا من الوفيات أو الحاجات اللي هتحصل في المستشفى، كده إحنا هنعمل سمعة كويسة للمكان. بالطريقة دي الليدرشيب برضو هيساعدنا في avoid the infection in our healthcare organization. طيب provide leader with targeted, valid and usable information to help them make decision about infection prevention. لما يبقى عندي delegate tasks، لما يبقى عندي إن أنا أفوض صلاحيات مثلا عندي رئيسة التمريض تعمل تفويض صلاحية لنيرس تشارج إن هي مثلا هي اللي تشيك على الاستاف إنهم بيعملوا الهاند هيوجين ولا لأ، they wear the PPE correctly or not. يبقى كده أنا عملت delegate task، اديتهم إنهم يقدروا يعملوا make decision about infection prevention، اديت task لحد تاني عشان يقدروا يعملوا decision معايا ويشاركوني في الديسيشن عشان نقدر نمنع حدوث العدوى في المكان بتاعي. يعني ما بقاش leader autocratic، أبقى ديمقراطي مش ديكتاتور. Okay. Assume leadership in the prevention of infection throughout the organization. We talk about it. Okay. The second one, teamwork and collaboration. Teamwork strategy for infection prevention professional. Foster collaboration and teamwork by engaging staff as partner in developing infection prevention policy. لما يبقى عندنا teamwork وتعاون ويبقى في عمل جماعي مع بعض، هنقدر ننفذ البوليسي والبروسيجر بتاعنا. They are the person who must implement them. هم طبعا التيم وورك والموظفين أو الستاف هم اللي هينفذوا. who must implement the policy and procedure. Encourage a multidisciplinary approach for infection prevention control. Learn about way to engage person from different disciplines to work together to develop solution to complex situation. لما يبقى في collaboration مع بعض نقدر نشوف حلول لأي حاجة معقدة أو مشاكل infection بتحصل عندي with our collaboration, such as how to care for a patient with a central line to reduce the risk infection. Participate with team of caregiver to address infection prevention issue. The first, maintain open communication about infection prevention to include staff and leader across the organization. لازم يبقى في عندنا open communication، تواصل فعال، تواصل مفتوح، محدش يبقى خايف عشان يقدر يبلغ عن أي حاجة بتحصل مثلا، أو يبقى في مناقشة جماعية عن أي عدوى، أي حدث حصل، أي حدث سيء أو حدث سلبي حصل، أو أي أخطاء حصلت، أي harm. فيبقى في open communication between the staff and the leader. Like such as we told before, no blame culture, then they can report about everything. Okay. Provide performance feedback so staff can evaluate the effectiveness of intervention and their work. This is teamwork and collaboration. Now we will talk about evidence-based practice. Evidence-based practice is strategy for infection prevention control professional. الاستراتيجيات المبنية على الأدلة evidence-based line. لازم دايما يبقى في عندنا update about evidence-based practice عشان نقدر نشوف إن إحنا ننفذها في المؤسسة بتاعتنا صح. يعني مثلا we have evidence-based practice about ال 5 whys. لازم we should have update. not مثلا عندنا like ICA or لازم يبقى في update للحاجات دي. ما بقاش مثلا من سنة like when we have the SIBAHI standards from 2016, it should be updated. It should be we have 2023 or 2022. Okay. Continually review new evidence-based literature to determine how it applies to the organization. Learn about the incentive and barriers to adopting and implementing preferred practice within the organization. لازم نعرف ايه العوائق او العائق اللي هيحصل لو ما نفذناش الايفيدنس بيزد بتاعتنا. وهيكون عندنا احنا في احيانا ان احنا مثلا ننفذ الايفيدنس بيزد فاكرين انها هتبقى للمستشفى بس، لا، ممكن يحصل قضايا، ممكن يحصل حد من المرضى يعني ده الاجراءات او العوائق او التوابع اللي هتحصل ان ممكن حد من المرضى يروح يشتكينا في المحكمة. يعني ال evidence-based practice is so important in the organization. Learn about incentive and barriers to adopting and implementation perform practice within the organization. Consider also issue external to organization in the greater community and how social culture, training of health professionals, and governance policy can affect the implementation of evidence-based practice. يبقى هنا external to organization greater the social culture، ثقافة المجتمع وتدريب الستاف والسياسات الحكومية بتاعتنا ممكن تأثر إن احنا نقدر ننفذ ال evidence-based practice. Become skilled in implementation science methodology, address implementation challenge in the planning of new and exciting policies and procedure for infection prevention. نقدر نبقى skilled في إن احنا ننفذ ال evidence based في تخطيط السياسات والإجراءات الجديدة اللي بتحصل بتاعتنا واللي هتكون قائمة على الوقاية من العدوى. لو عندنا update about it هيبقى سهل عندنا إن احنا ننفذ الحاجات دي. Organizational learning. How we will make organizational learning. عندنا بيحصل مثلا حصل infection في قسم معين وعمل ريت عالي وعمل ضجة في المستشفى كلها. تمام؟ احنا لازم نتعلم من الموضوع ده. ازاي؟ ننشر ثقافة ان حصل الموضوع ده already، نبقى في عندنا اقرار بان حصل عندنا الحاجة دي ونعلمها للناس التانية، نعلمها للأقسام التانية ونقول لهم إيه اللي حصل والتحسين تم إزاي، عشان ناخد دروس مستفادة للموظفين في الorganization. لازم يبقى في شفافية في الحاجات دي، تمام؟ يعني مثلًا يحصل عندنا مشكلة، فالمفروض حتى على الأقل مثلًا إحنا مثلًا مش عايزين نكبّرها ويطلع مثلًا للمرضى والكلام ده، لأ، ممكن نعملها كeducation للموظفين إن حصل قبل كده كذا والحل على طول. طبعًا الحاجات دي بتبقى مش علني يعني، فلمّا نعمل project والحاجات دي هنحسّن أو هنلاقي الحلول بسهولة مع بعض بعد ما نعمل الteams والكلام ده. ف يبقى نعمل بقى education أو training about what it's happened and why and how we find the solution. لازم يبقى في عندنا دروس مستفادة من اللي حصل عندنا. طب ممكن إيه تاني؟ إن إحنا نشجّع الموظفين إنّهم يشاركوا، إن إحنا نعمل سياسات، يعني مثلًا أروح مستشفى نمُر فيها يبقى فيها سباهي، طب يعني الموظف نَفْسه مش عارف أصلًا السياسة اتعملت إزاي. ما فيش coordinator in each department. طب how؟ لأ، أصل أصل الquality، قسم الquality هم بيعملوا لنا كل حاجة وإحنا بناخدها، لأ مش كده، لازم يبقى في آآ لازم يبقى في coordinator from each department. Sorry. We should have coordinator from each department. We should have staff knows about the policy and procedure and how to implement the policy and procedure. Okay. Organization learning strategy for infection prevention control professional. The first one, share infection information and learn lesson with all appropriate staff. The second one, encourage staff to participate in formulating policy and procedure to reduce infection risk. Form multidisciplinary teams. يبقى the first one, organization learning, share infection information, encourage staff to implement and formulate policy and procedure, form multidisciplinary team, use adult learning principle and creative presentation to educate staff. مبدأ adult learning we will talk later tomorrow or after tomorrow. هنتكلم عن adult learning، دي مبدأ خاص اسمه adult learning هنتكلم عنه later on. and creative presentation to educate staff. نستخدم مبدأ تعلم الكبار والعروض التقديمية عشان نثقف الموظفين. Gain organizational commitment to providing learning opportunity and associate resource. لازم يبقى عندنا organization commitment عشان نوفر فرص تعلم والموارد اللي بترتبط بالتعليم. Measuring care process and outcome. استراتيجية القياس. لازم نتأكد من أهمية التحليل والإبلاغ عن الموظفين والقيادة بتاعتنا، توعية الموظفين على دورهم في إن هم يبلغوا عن العدوى عشان نقلل من الثغرات اللي بتحصل ونصححها، أو نقلل من الأخطار اللي بتحصل ونصحح الأخطار دي، ويكون بشكل تلقائي أو متسق مع بعض عشان نحدد التعريف المختبرة للعدوى أو العدوى اللي بتحصل في الرعاية الصحية. Major strategy for infection prevention professional emphasizes importance of analysis and reporting infection, educate staff about their role, use test infection definition constantly to identify health association infection, provide a safe methods for staff، نوفر لهم طريقة يعملها الموظفين عشان يبلغوا عن الإصابات والحاجات دي ونشجعهم، ونديهم حوافز، يبقى في حوافز، في شهادات تقدير، في مثلا موظف مثالي، في الحاجات دي كلها عشان نشجعهم إن هم يقدروا يبلغوا عن أي infection أو أي حدث بيحصل في المستشفى rather than blame or punish reporting. This involves precise definition of colonization with infection, constant data collection process, accurate capture of data and validation of infection rate, stratify data whenever possible. Okay, for more precise analysis, for example, surgical site infection by type of procedure, anesthesia assessment, and duration of procedure and infection in the newborn population by breath weight, and indirect or risk for infection, an indirect indicator. In collaboration with the clinical and quality staff and other, بالتعاون مع الستاف والجودة وغيرهم، هنقدر نحدد ازاي نحافظ على السيرفيلانس أو here determine when to maintain or eliminate specific aspect of surveillance so that measure it focused and useful. كده نقدر نلاقي القياس بتاعنا مركز ومفيد. طيب revise risk assessment and develop action plan based on data analysis and timely dissemination of surveillance data. إن احنا نراجع تقييمات المخاطر ونحط خطط بنستند بيها لتحليل البيانات وننشر بيانات المراقبة في وقت مناسب of surveillance data. System thinking. When we have system thinking strategy for infection prevention control professional, when designing or updating policy and procedure for staff to follow, consider the entire system, how the individual part interact. هنخليهم لما نصمم أو نحدد سياسات وإجراءات يعملها أو يتبعها الموظفين، لازم يبقى في اعتبارنا إنه يكون للنظام كله. إزاي هيتفاعل مثلا الستاف مع السياسات والإجراءات اللي احنا حطيناها، وإزاي هيأثر التغييرات اللي هتحصل في المؤسسة بتاعتي بعد ما ننفذ الإجراءات أو السياسات اللي وضعنا. system thinking، إزاي نغير التفكير أو المعتقدات. طبعا الحاجات دي we have the resistance from the stuff. التغيير طبعا صعب وبيبقى بيطول، لكن we can do it يعني. How the individual parts interact, how can change will affect another, how the system should work، ازاي السيستم هيبقى كويس بعد ما نعمل السيستم thinking او نغير في المنظومة بتاعتنا. include all key stakeholder and test the system with a small pilot. زي ما قلنا اي حاجة بنعملها او اي تغيير هنقدر نعمله. عشان كده الميثودولوجي بتاع البلان do check act it's effective even in our life, not only the healthcare quality improvement project. Anything you want to do, check your plan, then implement in the small scale or small pilot. The do in BDCA, do means pilot also. Piloting. We did our plan in small pilot. Study before implementation it organization wide. يعني نعمل أي حاجة، مثلا السياسات اللي عملناها والإجراءات اللي عملناها وهيحصل فيها تغيير، لازم أنفذها في جزء معين صغير الأول، بعد كده هنفذها على المؤسسة أو المنظمة كلها. Ensure that the system provides for supplies that the staff can successfully perform the assigned task, that the infrastructure support the desired behavior, and that coordinate department supports the infection prevention process. The last one, work with others to design a system to achieve and sustain success. لازم يبقى في عمل جماعي ونعمل مع الأقسام التانية عشان نقدر نصمم نظام نحقق بيه النجاح بتاعنا، ويبقى نجاح مستمر ومستديم، مش نجاح وقتي فقط. Human behavior. السلوك البشري. We have three human behavior in the health, in the quality or patient safety, but we will talk about it later also in other lecture. Human behavior strategy for infection prevention control professional. Consider a change effort as it related to organizational culture and human behavior model. Engage staff in changing effort to better understand their values and motivation. Use behavior model when possible. في عندنا نماذج معينة لنماذج السلوك نستخدمها إذا كان ممكن عشان نقدر ننفذ بيه. Human factor strategy for infection prevention عندنا لسه human factor 3 and no blame culture and zero tolerance, effective and open communication, and what does the future hold for patient safety and infection prevention. Okay, still we have more slides, and I think we will stop in this time, and we have 10 minutes to questions أو أي أسئلة عايزينها أو أي إحنا خلاص يعني كده هنقف هنا عشان لسه فاضل فيه حاجات كده تقيلة شوية. هنقف المحاضرة هنا إن شاء الله دلوقتي، وعندنا 10 دقايق أو ربع ساعة نقعد نشوف نسأل فيهم أسئلة، عايزين أي استفسارات، عايزين حاجة أعيدها، عايزين مشروع نعمله تاني، أو تشاركوني إن إحنا نعمل مشروع أو like workshop now up to you يعني. يلا يا هيا، هو مفيش حد مركز معايا غير هيا يعني. You have any questions? We will stop now here until this slide. Then we will continue tomorrow, inshallah. After Dr. Noura also. You have any questions? You have any, you want me to do any project about infection control? You want me to repeat any slides? You want anything? عندكم عايزين أي استفسارات، عايزين أي أسئلة، عايزيني أنا أسأل أسئلة بقى؟ Thank you, Haya. Thank you. Thank you, really. Excellent, ya Haya. I'm so proud of you, really. Thank you, Ali. Thank you, Haya. Thank you to all. You have any questions? Yeah, thank you. Well done. Thank you, Tariq. Thank you, Ali. See you tomorrow. But I want you all to you understand everything already. And you have any questions? You want me to do? You want me to repeat any slides? Thank you, Ali. Thank you. Thank you, Haya. شكرا لكم كلكم والله. I'm proud of also Ali and Abdul Majid, Haya, all attendants also. Abdul Razak, thank you to you also. I'm thankful to all. Please, there is any questions? يا رب تكونوا أخدتوا حتى لو معلومة واحدة واستفدتوا بإذن الله. Thank you, Ryan. Thank you. Thank you, عبد الرزاق. أخدت معلومات. طب الحمد لله. شاركنا شوية معلومات يعني. Thank you to you. Thank you and excellent. Thank you, Foz. Thank you. شكرا لكم كلكم. And we will continue inshallah tomorrow, and we have lecture tomorrow and after tomorrow بإذن الله. Thank you. Good night to all. Thanks, Khulud. Thanks. See you, Johara. Yalla, goodbye.